This is a meeting of the Portfolio Committee on Health. It's the 13th of October at 1400 hours. We are about to receive presentations on the annual performance of the Council for Medical Schemes and the South African Health Products Regulatory Authority as we prepare our committee report towards the BRRR process. We will take attendance now. Ms. Majalamba, and apologies.
Good afternoon and thank you, Chair. Present is Dr. Jacobs, Mr. Munyai, Ms. Gela, Ms. Wilson, Ms. Ishmael, Dr. Tembekwayo, and Mr. Van Staden. Ms. Sukers will join the meeting later. Thank you, Chair.
Thank you very much. And also all the members from the National Department of Health who would have joined, you're also very welcome. And I don't see any other members from the ministry or anywhere else in the meeting platform. Before we proceed, honorable members, I need to read the rules again. And to remind you that this virtual meeting is deemed to be in the precinct of Parliament and therefore constitutes a meeting of the Committee of the National Assembly for official purposes only. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and privileges that apply in a sitting of the National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said to the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons on the bar at the bottom of their screens, which has an option that allows the member to put up his or her hand to raise points of order. The Secretariat will assist in alerting the chairperson to members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order or interjection. We will continue to receive the report and the presentation from the Council for Medical Schemes now at 1400 hours. And then we might have a break in between because the SAPRA is only able to join at 1700 hours and we'd invited them for that time. So honorable members, we would have to see how this goes. Dr. Sipho Kabane, you're very welcome. Please introduce your team and take us through your presentation. Thank you.
Afternoon, Honorable Chair and members. Today we're accompanied by our Chairperson of Council, Dr. Memela Makiwane, and I'll ask him just to say a few words and maybe introduce some of the council members present in this platform. Thank you, Chair.
Through you, Chairperson, thank you, Dr. Kabane. Honorable Chairperson of the Portfolio Committee, Dr. Jacobs, members of the Portfolio Committee, my fellow council members in attendance, and the Registrar of the Council for Medical Schemes and Management in attendance. Thank you, Chairperson, for inviting the Council for Medical Schemes to present its 2021-2022 annual performance report. Allow me, Chairperson, to say the Council for Medical Scheme is here to present a good story to tell, in that the Council for Medical Schemes obtained an unqualified audit report, which I'm sure the committee is aware of. The CMS has reduced the complaints backlog that has bugged us for a while in the past years, and it has significantly eased the financial hardships that would have otherwise been imposed on members, especially by deferring the contributions for tens of thousands of members that would have otherwise been prejudiced. We have performed very well, Honorable Chairperson, both operationally and financially, irregular expenditure was significantly reduced in comparison to previous years. We continue to also reduce the risk pool fragmentation, which is very much in keeping with our strategy in consolidating the risk pool at both the option and scheme levels, so as to enhance the coverage of healthcare access. And of importance, Honorable Chairperson, I would really like to take this opportunity to thank the Executive Authority for its support to the Council for Medical Schemes, particularly that which was shown to us when we went to the Executive Authority with a proposal for a new funding model, as that has been something that has bugged us for a while now. We would, however, really appreciate and value more regular engagements with the National Department of Health for such positive outcomes. Without wasting a whole lot more time, Chairperson, I understand that time is always a pressure point. I would once again say thank you for inviting the CMS for this presentation. I'm not going to introduce each of the board members present, but there is fellow board members present and a contingency of management in present. Over to you, Honorable Chairperson. Thank you.
Thank you, Dr. Kabane.
Right, thank you, Honorable Chair and members. It is indeed a privilege and an honor to present to yourselves the annual report of the Council for Medical Schemes for 2021. Chairperson and members, our presentation is going to be divided into 4 parts. I will do the annual performance report, and then my colleague, CFO, Ms. Zinja, will deal with the audited financial statements and the audit outcomes. And then Mr. Willie will talk to the industry trends. And then the final person that will address yourselves will be Ms. Skeppers, who will talk about the sustainability of the schemes from a finance point of view. Honorable Chair, we're acutely aware of the time constraints, so we will try and move as fast as possible so that we spread our presentation within the time given. So without any waste of time, Chairperson, the slide that you see in front of you just talks to our vision, mission, and values. And I'm sure committee members will look at that in order to understand what it is that we do. But to summarize our reason for existence, Chair and members, it's that we exist to protect the interests of members of schemes, and we also regulate the medical schemes industry in a manner that is complementary to national health policy. I wish to move to this next.
Through you, Chair, can the presenter please, we want to see the slides, not the other parts thereof. Can you make it bigger so that we can be able to move on with it? Sorry, Chairperson, for the intervention.
Just a slideshow. It's not yet. Honorable Munyai.
I can see the slide. Thank you.
There we go. Thank you.
Thank you.
Thank you very much. Of the Council for Medical Schemes. Yes, we've received the unqualified reports that the Chairperson has alluded to. And this is a continuation of a performance that we've had since we were established. And we've got ICT systems availability at 99%. And we've done two successful failover tests on our ICT system. We have succeeded in exceeding our employment equity targets. Our clinical opinions for complaints have been delivered on time, and publication in support of national health policy. And we believe we've increased our stakeholder awareness over the time that we were looked at. And yes, we have reduced the complaints backlog over the year in question. This next slide, honorable members, just talks to the overall performance of the Council for Medical Schemes against the objectives that have been set. You'll see in the last column on the right that actually we are reporting against 60 applicable indicators is period under reporting, and only could not achieve 10 targets. And that overall score translates to the overall performance of 83.33%. But we will go into details as we relate to the progress by each program. I also want to just draw your attention to the fact that we have analyzed the areas where we've had weaknesses, and we are currently putting in place strategies to address these areas of underperformance. And these relate to the manner in which we do target setting. We want to ensure that our targets are in line with legislation, that we improve our meaning and understanding of our target indicator definitions. We are making sure that our targets are smart. And basically, we believe that we're over the hump as an organization, because in the year under reporting, we were still migrating officials from an old to a new structure, and that process has been completed. So as we speak, we're in the process of filling some of these posts, which we believe are going to improve our performance. We're also busy cleaning up our annual performance plan here, so that we take away those operational indicators and keep them in our operational plans. And then, Chair, I'm going to start with the report of the specific program performance. And the first program is the Office of the CEO, which is program 1.1. And it's reflected in slide number 12, which is the current one and the next one. Basically, this program has got 4 outputs. The first one refers to the overall performance, which should be in excess of 80%. The second one talks to the annual performance report, which needs to be submitted to Council in July each year. The fourth output talks to the 4 strategic risk registers
Kabane, we seem to have lost your audio.
That need to be presented each quarter. And then the fourth one talks to, I don't know, can you hear me now, Chair?
Yes, we can now. Continue.
Thank you. So in this program of the CEO, all of the targets that were set for the year were fully achieved within the time that was allocated and the resources placed. So the next slide that I want to talk to is slide number 14, that refers to the Office of the Chief Financial Officer. This program, honorable members, has got
Dr. Kabane, we must lost you again. You maybe also set your video, but we see only half of you in that video. Are you frozen? Maybe.
Chair, maybe let me move over to my laptop.
Maybe you can switch off your camera for now while you're presenting. See if it improves your audio.
Okay, Chair, let me try that. Right, I've switched.
Yeah, let's see how it goes. Thank you. I definitely can't hear you.
Can you hear me now, Chair?
Now, yes. Now we can either hear nor see you, so I'm a bit challenged now. When I could see you, I could see you there. Now
Yes.
I don't know whether you're there and I can't hear you.
Chair, can I just?
Yes, let me give you 3 minutes to sort it out.
So, Chair, do we have 3 minutes break? Chair.
Yes, we have a 3 minutes break. We can take it till 20 past 2.
Okay.
We'll start at 20 past 2.
Okay, Chair.
Oh, it's gonna be better with the dog. The camera is off there, right?
you see my presentation, Chairperson?
Yes, I can. Just go back onto slideshow again.
Right, is it helpful, Chair?
That's great. Thank you.
Yes, Chair, I was still presenting the program of the Chief Financial Officer. And I was saying that this is on slide number 14, and that there are two outcomes for this program. Basically, it's our unqualified audit opinion, as well as the budget that the CFO presents to Council at the end of each January. And yes, both these two outcomes or outputs were achieved. And then moving on to the next program, which is the ICT. This program has got 5 outputs. Firstly, there's an output on the network and server uptime. There's an output on security incidents, disaster recovery, failover, the installed applications access, as well as per year requests. And Honorable Chair, all these were achieved except for the network and server uptime. Because there was a time when we were migrating to a new service provider. And for that time, there was an instability in the network and connectivity. So we dropped our performance from 98 against the planned 99%. On program number 3, Chair, which is covered in slides 15 and 16, this program has got, no, I'm talking to program 1.4, which is in slides 17 and 18. This program has got 7 outputs here. And the first one relates to the staff turnover rates, which we want to keep below 15%. The vacancy that get filled within 120 days, employment equity, the talent and policy management framework, the performance agreements and assessments, as well as training on staff employee relations. Against all 7 outputs, Chair, there was a good progress on 5 of these here. And the only 2 areas where we could not achieve our target was in the appointment turnaround times of 120 days here. We inadvertently included posts that we were actually terminating in our denominator. And these are the posts that were being terminated as a result of the restructuring. So that forced us not to achieve. But then the talent and policy management framework took more than what was anticipated. So it could not be approved on time. So that was another area where we struggled. But I move on, Chair, to program 1.5, which is on slide number 19. And in this program, we've got 2 outputs, and these relate to legal services. The first one talks to verbal and written opinions given to internal and external stakeholders. And the second one talks to us being represented in the various tribunal. And I'm happy to announce that both of these targets were met. And then in program number 6, which is the Secretariat of Council, we had 5 outputs against which we set indicators. The first one talked to the council having a work plan for its work. The second one was the revision and development of the charters. The third one was around record keeping and resolutions. And then the last 2 was talking to the appeal committee and appeal board sittings, as well as rulings being published within 14 days. Against these 5 outputs, 3 were achieved. And the only areas where there was no achievement or achievement below the target, this refers to the 2 outputs that relate to the appeals committee and appeal board meetings, as well as their rulings here. And the reason for that here is that our secretariat is actually understaffed and could not support these processes. The next program that I want to talk to is program number 7, which is the strategy, and the slides are reflected in slides 22 and 23. This program has got 7 outputs, and basically these refers to mainly the prescribed minimum benefit definitions, the review of the prescribed minimum benefit, as well as the clinical opinions that are issued at 30 days, 60 and 90 days, and also the urgent clinical opinions, as well as research supports that are clinical in nature and that we were undertaking in support of the NHI. This program was able to achieve all its intended targets within the time and the period envisaged. So the next program that I want to talk to Chairperson is program 3, which is accreditation, and is in slide number 24. This program has got 3 outputs: accreditation of brokers, managed care organization, and administrators. And all the outputs in this program were achieved, Chair. I wish to move on to program number 9, program 4, which is on slide number 25. And this program has 2 outputs, namely research projects in support of national policy, as well as industry trend reports that sits in our annual report. Both of these outputs that sit in this program were achieved in full. The next program that I want to talk to, Chair, is the Stakeholder Relations. And this is covered in slides number 26 and 27. And basically, there are 5 outputs in this particular program. The first one talks to stakeholder awareness training that our colleagues go out and do to the various areas. The second one talks to stakeholders being aware of CMS. The third one talks to the contribution of this unit to the annual report. The fourth one talks to stakeholder education. And the last one talks to interventions that are done through the call center. For this program, Honorable Chair, all the 5 outputs that we had set our target against were achieved. The next program that I want to talk to, Honorable Chair, is program number 6, which is compliance. It's covered in slide 28 up to 30. And basically this program has got 5 outputs. It makes reference to routine inspections that we go out and do to the entities that we regulate. Also commissioned inspections, which we do after people have complained or if we are anonymous hotline tip-offs. It also talks to enforcement activities. Chair, can you hear me?
Yes, we can. Just continue.
Thank you, Chair. So out of the 5 outputs that were set against this program, all 4 were achieved, Chair, except the Commission's inspections. And the reason for us not achieving this were the delays in the process of finalizing these commissioned inspections. And then in the next program, Chair, it is around benefit management. And this program has got 2 major outputs, basically the registration of interim as well as annual rules. And I'm happy to report that both of these outputs were actually achieved, and these sit in slide number 31. The next program, Chair, is financial supervision. It's covered in slide number 32 to slide number 34 and refers to the work of financial supervision. There were 5 outputs that were set out. The first one was ensuring that schemes that have got a solvency of less than 25% are closely monitored. The second one relates to an indicator that says when schemes have got a solvency that is rapidly declining, irrespective of the level where they sit, they need to come to us and we look at their business plan. The third indicator talks to auditor applications. The fourth one talks to quarterly industry reports. And the fifth one talks to the unit's contribution to the annual report. All of these five outputs were achieved, Chair, except for the auditor application. And this is just a process issue where one scheme actually submitted their report right at the tail end when we were supposed to make the final report. As a result, that application could not be processed. And we achieved a 99 instead of 100% as reflected in slide number 33. And then, Chair, the last program that I wanted to talk to, it's complaints adjudication. And this program had 6 outputs. The first one basically looking at all complaints that are around 120 days, which is our main turnaround time. But then these were broken down to also complaints dealt with within 30 days, 60, 90 days. And it also refers to a target of publication of rulings, as well as appearance of in the appeals committee. Out of these 6 outputs, 3 of these were achieved. And where we struggled was with the complaints that are 30, 60 days, as well as the publications of rulings. And the reasons for this, Chair, was mainly the fact that when this target was set, there was an oversight in not taking into account all the dependencies. But these are the small little issues that I've mentioned earlier on around target setting, which we have corrected for the current APP that we are putting in place. Chair, that is where I would end and ask my colleague, the CFO, to present to yourselves the audited financial statements and the audit outcome. Thank you, Chair. CFO, I'm going to stop sharing, and I'm hoping that you'll be able to do that on your own then.
Okay, I'll check Dr. Kabane. I am unable to project on my side. It says the host has disabled.
I'm sure Ms. Majalamba will sort it out for you now.
All right. It is sorted. Is the screen visible on your side, Honorable Chair?
Yes, thank you. Please proceed.
Okay. Afternoon, Honorable Chair, Honorable members, all protocol observed. So I'll be taking the committee through our financial performance and audit outcome. Just a few opening remarks, Chair.
Sorry, Chair, through you, Chair, can the presenter raise the voice, please? We can't hear her clearly. Through you, Chair, sorry. We can't hear her.
All right, please try Ms. Zinja.
Okay, am I clear now, Chair? My volume was low.
I can hear you well, but maybe a bit louder if you can, maybe. Just speak more into the microphone or whatever else you can do.
Okay, I'll try to raise my voice a bit more, Chairperson. Right.
That's better, yes.
All right, thank you. Just a few opening remarks, Honorable Chair. Last time when we invited to the Portfolio Committee to table the previous year's annual report, we tabled a report where we said that we had significant—
Honorable Chair.
Honorable Munyai.
I can't hear the presenter, please.
I support you.
Ms. Zinja, let's try again. I hear you very well.
I'm not sure. I've taken off the earphones, Chairperson. Can the other members still not hear me?
Let me get a round of the members to
That's
hear.
better. That's
I hear you
better.
very
We
well.
can hear you now.
Hold on.
We can
Going
hear
one
you
by
now.
one. Honorable Munia, is it better?
Yeah,
Yes,
the
very
screen
better.
can't move. I don't know.
Honorable Tembakwayo, is it better?
It's better, Chair. It's better, Chair, but let her keep her voice very much audible, please.
Thank you. Honorable Kaba, your hand is raised. Honorable Kaba, or you want to lower your hand? Let's continue, Ms. Zinja.
Okay, thank you, Honorable Chair. In the previous financial year, committee members, when we're invited to come and present the annual report to the portfolio committee, we tabled an annual report for finances that showed that CMS was in difficult financial situation. So we showed a dire financial position where we had a significant amount of debt, we're struggling to pay our creditors, and we had serious cash flow challenges. Now, it pleases me, Chair and honorable members, to come to this committee today and present a positive report with a positive financial position for CMS. So I'll be taking the committee through our audit report and also our financial statements. In terms of our audit opinion, honorable members, we've received an unqualified audit opinion from the Office of the AG. We've always maintained this unqualified audit opinion. However, would like to move to a position where we obtain a clean audit opinion as the CMS. Also, when it comes to our performance information, we've received no material findings when it comes to the usefulness and the reliability of the performance information. So this sends a good message about the quality of the reporting information that CMS uses. We acknowledge that there are some compliance issues that we have, and these are a key focus area for the organization. We'd like to move into a position where we eliminate any irregular or fruitless and wasteful expenditure. This has already started. We've seen a decline in this 2021 financial year in terms of irregular and fruitless and wasteful expenditure. Now, honorable members, when it comes to our financial position, in the previous financial year, we had reported that our liabilities were sitting at 62% of our financial position, with just 38% being our assets. Obviously, that's not a good position for any institution. So in a space of 12 months, we've been able to move to a position where our assets constituted 52% of our financial position, with liabilities sitting at 48%. This came about through rigorous oversight by the council. And also we try to strengthen as far as possible our budget management controls and push down costs as far as possible to be able to pull us out of that difficult financial situation to the position that you are currently seeing. Yes, we accept we're not completely out of the red yet. However, looking at this picture and these two pie charts, honorable committee members will see that it's been a huge shift from the 2020-21 financial year, moving now to the 2021-22 financial year. And we want to continue to strengthen this moving forward. And as part of strengthening our financial position, yes, we have looked at our expenses and tried to push those down as far as possible. We've looked at the controls when it comes to budget management. We've strengthened those. And there's also the revenue side of things. Our revenue as CMS, well, we are mainly funded via levies that we collect from schemes. Our revenue is influenced or governed by our Act. Our Act is over 20 years old. And when it comes to our funding, our Act has never been reviewed and our funding model has never been really looked at to ensure that it's still it's up to times and it's changing with the changing contextual environment. So currently what CMS is doing, there is a committee put together by council through the registrar that is to review the funding model that is being used by CMS. The main purpose is to see if there are any areas where we can go about raising additional revenue as the organization. As we can understand that when it comes to financial sustainability, you don't just look at one side of the coin, which is your expenditure side. You also need to look at other strategies when it comes to raising revenue and collecting more as the organization. So we'd want to get to a position as CMS where this pie chart you see here is diversified and there's more revenue that is being brought in by the organization. We have started with that review of the funding model. We are anticipating sometime next year, we'll be engaging more with the Department of Health, with the Minister, and at some point in the next financial year, we will come table something to this portfolio committee, honorable members. Now, moving in more detail when it comes to our expenses that we reported on in the current financial year that we're reporting on. In 2020-21 financial year, yes, our expenses were high. They were sitting at about 190 million rand. However, there's been a huge shift into the 21-22 financial year where our expenses are declined by over 13%, sitting at 165 million rand, again, due to those strategies we've employed. Part of our expenses, the declines is mainly in the operational costs, but every single part of this pie chart has dropped from the 2020-21 financial year to the 2021-22 financial year. We have not just focused on just one area. We've tried where possible to try and contain and manage costs at different areas of the environment to ensure sustainability. I will talk a little bit more on the detail of the running costs that we have as the organization, comparing the previous year to the year that we are now tabling. When it comes to administrative costs, honorable members, administrative costs are those standard running costs of any organization. For us as CMS, the key cost drivers when it comes to your administrative costs, your telecommunication, mainly because of COVID, and to be able to be accessible to the external environment, and also your rental and office maintenance related costs. Your telecommunication, because of COVID, these have been high. You'd see in 2020-21, highlighted by green, that this has been significantly high. Moving into 2021-22 financial year, where employees were starting to move back into the office, those started to decline and stabilize as employees are now working from the office. But when you look at the rental and the office building related costs, that is based on the agreement that we have with our landlord. We do not own this building, we are leasing them. However, the lease is soon coming to an end. So currently, as the organization, we're looking at various strategies of trying to push those costs down. And also one of the strategies we're considering, it's influenced obviously by the virtual working environment, asking ourselves the question, do we really need an office space? Can we not redirect those funds elsewhere? Do we need a bigger office? Do we not need a smaller office space? So it's part of the discussions that we are having currently internal with the aim of being more productive and more efficient as the organization, but also driving the costs down, especially these key cost drivers for the organization. Now, moving to the operating costs, Honorable Chair, your operating costs are project mainly related costs. Here, it pleases me to report, honorable members, that when you look at our key cost drivers, mainly here being your consultancy, being your legal fees, the committee will notice that there's been a significant drop in the legal fees comparing the 2 years. There's been a 64% drop in legal fees from 2021 up to now, the 2022 financial year. That's mainly because, again, of the controls we've put in place. We've put in place a committee that looks at every single litigation matter and advises the registrar, looking at the cost-benefit exercise, whether to defend, to litigate, or how to move on each specific matter. So that is with the aim of ensuring that we only target those cases that are key and that we're going to make impact in terms of our regulatory work as CMS. Also, it again pleases me to report, Honorable Chair, that when it comes to your labor relations costs, there's been a significant decline of 69% in the costs that we've incurred as CMS from the previous financial year into the current financial year. So also when it comes to your consulting fees, yes, there's a small increase there of about 4% when it comes to the consulting fees. What drives our consulting fees at CMS are your PMB reviews. We need medical specialists that we cannot employ as part of our salaries or of our COE, because that's a permanent cost. And we need various different kinds of skills that we bring in as and when required. So that forms part of our consulting fees, consulting costs, where we ask specialists from the industry to assist us when it comes to other regulatory work and PMB reviews. Also, that consulting fees houses investigations and appeal board work. When it comes to the appeal board started doing its work in the 2021-22 financial year. As the committee will recall, that there was a period where the appeal board was not, we did not have an appeal board as CMS. However, the minister did select people to be part of that appeal board, and it has started.
Excuse me, sorry, Chairperson, through you, Chairperson. I'm really lost here. From the slide that is presented here, the statement of financial performance and what the presenter is presenting, I am lost. I don't understand what she's talking about. Can you intervene, Chairperson? What she's reading and what is here is different.
Can you maybe go a bit slower and move with your slides? Thank you.
Okay. Are we on slide 45, Chair, on your side?
I'm looking for your number. Yes, for slide 45.
Oh, okay. So slide 45, Honorable Chair, shows our operating costs as CMS. So what we are saying in this slide, we are showing the 2 financial years. In green, we are showing 2020-21 financial year. In blue, we are showing the current financial year that we're reporting on, which is 2021-22 financial year. What we are saying in terms of the operational cost, we've seen a decline from the previous financial year to the current financial year when it comes to CMS's operational cost. Specifically, the key cost drivers here on the operational cost is your legal fees. The legal fees have declined quite significantly. You'd see there that in the previous financial year, as highlighted by the green, we showed 23 million rand worth of legal costs that we incurred as CMS. However, now, as shown by the blue, in the 2021-22 financial year, legal costs are below 10 million rand. So meaning that there's been more than 30 million rand worth of savings or worth of cost containment when it comes to the legal costs. That's thanks to the strategies that we have put in place to manage and contain costs as CMS. And the second part, Honorable Chair, is that when it comes to your labor relations costs, again, there's been a decline from the previous financial year, which you can see as a blue of 3.1 million to the current financial year, which is now a blue, which is about less than 2 million. Again, it's for CMS trying to manage these costs. However, I'm noting, Chair, that there's a slight increase when it comes to consulting fees when you compare with the previous years, and also when it comes to council members' fees when comparing it with the previous years. The reason for that increase, firstly, to start with the council members' fees, the reason for that increase is because of the number of engagements that we've had with council in the 2021-22 financial year in giving oversight for the organization to move us into this positive also financial position as the organization and ensure performance by the organization. And the reason for the increase in consulting fees, it's mainly because the appeal board now has started functioning for CMS starting the 2021-22 financial year. So this slide, its main purpose is to show the makeup of what influences our operational costs and also to explain where there has been a slight increase or a decrease, Chairperson. Now, moving to the compliance-related matters, when it comes to irregular expenditure, and then when it comes to fruitless and wasteful expenditure. Now I'm on slide 46, Chairperson. This is an area of focus for CMS. there has been a decline in terms of the irregular expenditure and fruitless and wasteful expenditure from the 2020-21 financial year to the 2021-22 financial year. You'd see on the slide where irregular has moved from 67 million to 57 million, and fruitless and wasteful from 567,000 to 328,000. This is mainly because of the controls again put in place within CMS. We have put together a loss control committee that looks specifically at these non-compliance matters and investigates the responsible party and where there's been a breakdown in internal controls, and see how we can strengthen controls to ensure that these matters do not occur again. And also making sure that there is some sort of consequence management and recommends a proper way forward to the registrar and to council chairperson, whether we recover the funds, whether we condone, and whether there should be disciplinary chairperson. So this is an area of much focus, and we are aiming to ensure that we eliminate any kind of non-compliance and irregular expenditure moving forward. The last slide, chairperson, is just to conclude to say that in terms of our finances, we have moved quite positively from the previous financial year to the current financial year as CMS. When it comes to our liquidity, if you look at the cash in our bank, in the previous financial year, when it came to this committee, we had reported that it only constitutes 15% of our total assets, the cash that we have. Now we are pleased to report that it constitutes 48.6% of our total assets. Same when it comes to the coverage in terms of our current liabilities, the cash that we have. In last year, we had said that it only covers 11% of our current liabilities. In the current year, Chair, it covers 60% of our current liabilities. Therefore, we were able to move from a position where we reported a deficit of 4.7 million rand in the previous financial year as CMS to a surplus of 24 million rand in the current financial year, honorable members. And for the first time in a space of 3 years, we have been able to move from reporting an accumulated deficit as CMS to an accumulated surplus position as the organization. We will continue, Chair, working on our long-term sustainability model as CMS to ensure that we are able to continue operating financially sound as the organization. That is the last of my slides, Chairperson. I'd like to hand over to Dr. Kabane.
Yeah, thank you, Honorable Chair. The next presenter will be Michael Willie, who will take us through the industry trends. And yes, Chair, we have asked the next two presenters to be very short because of the time constraints. Over to you, Michael.
Yeah, thank you, Doc. And then good afternoon, honorable members of the Health Portfolio Committee. I will request that Andisa drives the presentation from her side so as to save time, because I will also need permission to be able to project. So CFO, if you do not mind, can you please reproject on my behalf? I'll also be brief. Thank you for the opportunity once more. My presentation covers 3 areas, members of the Health Portfolio Committee. The first one is the performance of the industry in terms of demographics, benefits paid, and then the last part would be on utilization statistics. You can go to the next slide, CFO. You can skip the outline, presentation outline. So this slide, members of the Portfolio Committee, it just depicts the number of medical schemes that were in operation in 2021. So we had 75 medical schemes that were in operation in 2021. It is one a decline if we were to compare it to 2020, because in 2020 we had 76 medical schemes. So that decline is because of a merger that took place in the year under review. But obviously, in terms of accounting standards, if one looks at a point in time, let's say December 31 of 2021, we had 73 medical schemes. So it will be the merger that took place between Hosmed and Sizwe, and then another merger that took place between Quantum and Discovery Health. So it's 75 because those are the schemes that were in operation in 2021. You can go to the next slide, CFO. And then in terms of membership, so if you look at the medical scheme membership as a proportion of the population, 16% of the of the population belong to medical schemes in 2016. And this figure declined to 14.86 in 2021. So over a period of 21 years, we see a slight decline. So it's just under 15% in 2021. So we've got two types of schemes in the sector, open schemes and closed schemes. Open schemes, which freely enroll everyone, accounted for just over half of the industry. But overall, in terms of membership, the industry declined by 0.5% if you compare 2020 to 2021. Next slide, CFO. So this graph, it just shows you how the membership has evolved over time from 2000. But specifically, if one looks between 2019, 2020 and 2021, you will see there's a decline between 2019 and 2020 from 8.99 million lives to 8.90 million lives in 2020. And that was as a result of COVID-19. It affected the medical schemes, the enrollment of beneficiaries in medical schemes. But we see an uptick if you look in 2021, because there was an increase from 8.90 to 8.94 million lives. So we see that 0.5 increase in terms of membership. So even though the COVID-19 had an impact, but it's not as pronounced in medical schemes industry as one would, as well as if you were to compare to other sectors. Next slide, CFO. So this slide, members of the portfolio committee, depicts the membership by three stratification: open schemes, closed schemes, and as well as industry. So you see the 0.5 increase between 2020 and 2021. The decline in open scheme mainly occurred in terms of dependents, because if you look at main members, there was an increase. But if you look at dependents, there was a decline from 2.5 million to 2.48 in 2021. So the decline there was mainly observed in open schemes, but closed schemes, they saw an increase of 1.1%. Next slide, CFO. There's a few schemes which we call the winners and losers, but these ones specifically, they're schemes that gained membership if you compare 2020 and 2021. But in the main, they experienced an increase of over 5%. The first one that you see is with an increase of 27%. That is a result of the merger that took place between Hosmed and Sizwe. Other schemes saw an increase of just under 10%, but more than 5%. Even some of the bargaining council schemes like Fish, industry medical schemes, saw an increase of just under 6%. And then obviously, in terms of the closed schemes, restricted schemes, there was an increase in a few of them, but GEMS contributed in terms of the largely because it's the biggest closed scheme, so it contributed in a great deal in terms of membership increase in closed schemes. Okay, next slide, CFO. So in terms of demographics, there's three areas that I wanted to depict on this picture. The first one is just the change in demographics of members who belong to medical schemes. It increased from 33.4 to 33.6. And then in terms of pensioner ratio, this is the percentage of pensioners who belong to medical schemes. It increased from 8.9 to just 9% on the dot in 2021. But the slight change that we saw was just a slight decline in terms of dependence ratio. But we saw in the previous slide, like I explained, that mainly came through from the closed scheme. Next slide, CFO. So this is the benefits paid in 2021 compared to 2020. Medical schemes paid 205 billion for relevant healthcare services in 2021. And then 90% of that they came from risk, and 10% of that came from the savings account. This is just a small, and I wanted to correct on this slide, members of Parliament. The 159 that you see there, it's supposed to be in bracket, is 2020. The actual risk benefits paid for 2021 is 185 billion rand, but that also still accounts for 90% of the 205 billion rand you see there in the first bullet point. Next slide, CFO. And then this is just the distribution of benefits paid across disciplines. In the main, in terms of total benefits paid, private total hospitals accounted for the lion's share, for the bigger percentage of 36%, and then specialists accounted for 26%, and medicines accounted for 16%. And then supplementary and allied healthcare professionals accounted for just under 8%. All those three disciplines combined, they account for 85% of all benefits paid. And then these proportions, the distribution again differs if one looks at the risk benefit as well as the savings benefit. For the savings benefit, a biggest proportion of that is taken up by medicines dispensed, followed by the benefits paid that were paid for specialist services. And then the next will be benefits paid for allied and health professional services. Next slide, CFO. And then this slide is just to show the trend over time. I think the main thing we wanted to depict is just the impact of COVID-19, in a sense that we saw a decline in the main categories: hospital expenditure between 2019 and 2020, also in specialists, but medicine sort of like maintained the same trend. But we see things starting to normalize in 2021 because the levels that you see in 21, they mirror what we saw in 2019. As a result, now, if one looks at the expenditure in terms of benefits paid for healthcare services, it will increase something that is more pronounced, higher than 10%. That is mainly because we start on a low base. This is what we'll see in the next slide. Next slide, CFO. So if you look at the benefits paid for private hospitals in the main, it increased a double digit of 10% from 67 billion rands to 74.3 billion rand. So this increase is higher compared to previous years because of the fact that we're starting at a low base of 2020. Similarly, with specialists, I mean, the increase in terms of benefits paid is just under 9% at 9.0. And then if one adjusts that figure in terms of inflation, as well as the utilizing beneficiaries, it's 9%, which increases from 5,562 to just over 6,063,000 rand in 2021. Next slide, please, CFO. So this slide is just depicting the one of the main important components of the Medical Schemes Act, which is the PMB. PMB accounts for just over 50% of benefits paid. But in the main here, what we see in terms of expenditure trend, the main contributors is it basically increases with age. That's the first thing, because we see older age profile accounting for a higher expenditure pattern. Similarly, with those beneficiaries who are younger, like those who are younger than between the ages 1 and 4, they also account for some percentage of benefits paid. But others, also the childbearing age around 25, 29, it's got a slightly higher uptake. But in the main, the distribution of beneficiaries of expenditure vis-a-vis the population, which is what we see in the bar graph, slightly differs, because the main contributors, it will be like your older age profile, as well as those who are younger than 4 years of age. Obviously, even in between, you see some expenditure patterns taking place there. But the main messaging in this slide is the fact that PMBs account for 52% of benefits paid in 2021, a slight increase compared to 2020. Next slide, CFO, please. This is basically the similar pattern, but the main message here is that for an ordinary member who utilizes healthcare benefits, but is not like sick, doesn't have a lot of chronic conditions and so on, ordinarily this person will be spending around 22,970 rand on an annual basis. But if somebody is between the ages of 80 and 85, the data depicts that that person will be spending on average around 75,000 rand. But we know that is a function of age as well as chronicity of the condition. For somebody about 44 years of age, that beneficiary will be spending around 22,000. But on the other side, on the right-hand side of that, of the graph, meaning therefore that somebody older than 44 years of age, then the expenditure increases as well. Next slide, CFO. So basically there's few issues that I wanted to depict here. The first one is the fact that in terms of the consolidation in the industry has slowed down, the number of schemes have declined, but we see a recovery insofar as beneficiaries are concerned, because there was a small decline if you compare 2020 and 2021, but we're seeing now an uptick between 2020 and 2021, indicating that the industry is recovering in terms of lives that are actually covered. We saw the impact of COVID-19, which mainly came through from the benefits paid, because we're starting on the low base in 2020. We see a lot of increases that were double digit in the main. And then the last messaging here is the fact that possibly because of financial pressures in the open schemes, as well as the affordability constraints in the industry, that decline, small decline in terms of dependency ratio, which could be attributed to some main members because of financial pressures, will result in terms of dropping off some of their dependents, just to ensure that they maintain coverage insofar as health insurance is medical aid membership is actually concerned. But we see an increase insofar as the utilization of healthcare services are concerned, because during the COVID period, there were some of the elective procedures that were deferred. A lot of the times, most of the beneficiaries did not visit healthcare facilities, but we're seeing now a release of pent-up demand, hence some of the increases. But if we were to focus to 2022, things are likely to normalize and stabilize. So that's the last slide. Thank you, Chairperson. Thank you, Dr. K.
Right, thank you, Honorable Chair. The next presenter will be Julindi, and we'll ask her to also be very brief here. Over to you, Julindi.
Thank you, Dr. Kabane. Good afternoon, Honourable Chairperson and Honourable members of the Portfolio Committee. As Dr. Kabane has said, I'll keep my presentation very brief. We'll touch on the financial performance of medical schemes over the past, for the 2021 year, as well as a few industry trends. So the first slide that I want to speak about is the snapshot that is a pie chart that looks at the distribution of the healthcare rand. This graph illustrates that for every 100 rand that's been spent in 2021, 91 rand was spent on claims, almost 9 rand was spent on non-healthcare expenditure, and 40 cents was allocated towards reserving. So this graph clearly depicts that medical schemes priced to break even on a net healthcare result level during 2021. CEO, if you can please move to CFO, can you please move to the risk relationship between contributions and claims? I think it's a little bit on. It's the next slide. Thank you. So in 2021, a total of 205 billion rand was collected in risk contributions from members, and expenditure on relevant healthcare services or claims was reported at 187 billion rand. In the past few years, we've seen the high claims ratios reflect inter alia the tariff pricing problems and the aging population. So you'll see that there's a significant drop from 2019 to 2020. From 2019's 90.58% claims ratio to 2020's 81.38% claims ratio, and that's depicted by the orange line on the specific graph. So that was due to the postponement of the elective procedures in response to the COVID-19 pandemic. Then you can see that the release of the pent-up demand, as well as the collective COVID-19 expenditure in 2021, resulted in an increased claims ratio of 90.94% in 2021. CFO, if you can then skip again to graphs to go to the trends in non-healthcare expenditure. So if you look at this graph, you'll see that the dark blue area represents gross administration expenditure. The green represents the managed care management services. That is not accredited managed care management services, because that is included in claims, and then broker costs is depicted in orange. And you can see that in real terms, non-healthcare expenditure per average beneficiary per annum has decreased. So this decrease represents one of the success stories in the medical schemes environment. So the curbing of fraud, waste and abuse still remains a key focus area for the Council for Medical Schemes. When we analyze the individual pricing of medical schemes, we continue to query individual schemes with high non-healthcare on the efficiency of their providers. And we request indication of whether additional services and value was added through these contracts. We issued Circular 77 of 2019, which requires schemes to unbundle the contracting by medical schemes and the standardization of the definition of their services, which will allow for comparability in future periods. The health market inquiry also alluded to the need for this. So there's an emphasis now placed on value-based contracting and ensuring that member-centric interventions are implemented where the interests of the scheme and the members are aligned. In the next slide, we see the net healthcare results and the net surplus. The green line represents the net healthcare results. The blue line represents the net surplus or deficit. And then the gap between the two represents the reliance on investment income. You'll note from that the axis on the left, the y-axis shows that all medical schemes made over the past 5 years incurred net surpluses. So there was no need for reliance on the investment income to turn a surplus deficit position into a surplus position. So the net healthcare result, which is the green line, represents the positions after benefits and non-healthcare expenditure are deducted from contribution income. So in essence, the operating income of a medical scheme. The net healthcare result for all medical schemes combined was 821 million rand in 2021. You'll also see that the gap between the green and the blue line widens between 2020 and 21, which is the reason being that the financial market rebounded during 2021. So the blue line, which represents the net surplus of all the schemes combined after investment income, was 12.2 billion rand for 2021. The next slide shows the solvency of the industry. You'll see that the solvency is at 46.73%, which is a very healthy situation. The reserves of medical schemes serves to protect members' interest and to guarantee the continued operation of medical schemes. They also serve as a buffer against unforeseen large-scale events, such as the COVID-19 pandemic. Schemes provided various financial relief measures to members during the COVID-19 pandemic, such as utilizing the personal medical scheme's savings accounts to offset contributions, the relaxation of credit policies, contribution holidays, and lower future increases. Schemes reserves will be utilized when the pent-up demand is released in coming years, and we've seen that to some extent in 2021 in the last quarter. And if we look at what this financial supervision unit of the Council for Medical Schemes had seen in 2022, there is a further release into 2022. We've also noted that there was a decrease in screening activities during 2020, which would also affect downstream costs, as early detection normally results in lower costs and better clinical outcomes. So the full impact of the pandemic is therefore not confined to the COVID-19 related claims itself. So for 2021, the medical schemes regulation 29 reserves increased by 8% and ended the year at 106 billion rand, whilst the solvency increased by almost 5% to this 46.73 that's been depicted in the graph. Andisa, if you can please move, that was my last slide, if you can just move to the conclusion. In the conclusion, there's 2 points that I wanted to bring to the attention of the Health Portfolio Committee, and that is that the medical schemes industry remains financially sound, but that the long-term effects of the pandemic on scheme reserves is still unclear and needs to be monitored. Thank you very much, Honourable Chairperson and Honourable members of the Portfolio Committee. That is then the end of my presentation.
Right. Thank you very much, Honorable Chair. So in conclusion, we just wanted the Portfolio Committee to note the performance of our institution that has achieved the 83.3% outcome, the positive audit report, and the fact that we actually complained to the Competition Commission and succeeded in getting the COVID-19 test, the PCR test, to be reduced from 850 to 500. And that became a 41% reduction. And I'm sure many schemes and individual members actually benefited to that extent. We also wanted the Portfolio Committee to note the fact that the operations at CMS are sound, We're making a surplus. We've reduced legal costs as well as consulting costs. But we're also assuring the portfolio committee that we're regulating a very sound industry whose numbers are actually stable, and we've managed to take control of non-health care expenditure. Yes, something still needs to be done to address that even further, but we're quite happy with what we have achieved on the average solvency that we see in the schemes environment. But Chair, we also come to yourselves seeking support here for our sustainability financial model, which we are busy putting together. And we've already come to yourselves to seek assistance on the finalization of the Section 59 investigation. And we hope to get your sustained support around that. But we are promising that we're taking those steps moving towards a clean audit. Thank you very much, Chair and honorable members.
Thank you very much, Dr. Kabane, your whole team, including Ms. Inja, Ms. Kippers, and the others who have presented, also your chairperson, Dr. Makiwane. The honorable members have wanted to raise some points with you. Let me congratulate you on your unqualified audit report or opinion. And also to note that you've made some great strides in trying to address some of the issues which have been outstanding, which we have been raising and yourselves have been raising consistently since we've been here since 2019. And I therefore can say I can see the progress that you've been making as the CMS. And I'm really proud of that. And towards the end, I will raise some points myself. The honorable members would wanted to raise some discussion points with you. Honorable members Ismail, Van Staden, Clark, Demarcation, Chirwa, Wilson, Munyai. Anyone else? Ismail, Van Staden, Clark, Demarcation, Chirwa, Wilson, Munyai, in that order. Thank you very much.
Thank you, Chair, and good afternoon to the Chair and to the colleagues and to CMS and the panel. I just have a few clarity-seeking questions. Number one, please update the committee on the restructuring process that is being implemented. How will it be impacted by the resource constraints from the CMS and that the CMS envisions? Secondly, how are you addressing the retention of staff given the high turnover rate of previous years? And my last question actually is related to what the last presenter stated now. I wanted to find out, I wanted to get an updated report regarding the Section 59 investigation panel. Thank you, Chair.
Thank you, Chairperson. I think there's 3 urgent matters that need to be discussed today, and I've prepared for it, that I want to talk about. It's my view that the annual report of this register is has a bit of a delay in information. Excuse me. I just want to know, why didn't the CMS not act quicker to intervene in the health squared medical scheme situation to avoid the hardship members suffer due to the liquidation which is currently happening? I see that Medipos are another disaster waiting to happen. And I would like to know how many other medical schemes are in danger of collapsing, and when will we as a committee hear of it from you as the regulator? I think James is a beautiful example what happened to them, that we as members had to engage you on in 2021 in this committee. Is it possible that the regulator can provide us with a detailed report on medical schemes that are currently in danger of collapsing? My second question is, there seems to be a lack in complaints and appeals being adjudicated in terms of Section 47 to Section 50 of the Medical Schemes Act. My question on this is, what will the CMS do to ensure that complaints are adjudicated within at least 90 days. And then my third question is if you look at Annex A of the regulations promulgated in terms of the Medical Schemes Act, that states that prescribed minimum benefits must be amended every 2 years to keep pace with changing treatment practices. And it's, according to my knowledge, it was not amended since the 1st of January 2000. Now, the payment of prescribed minimum benefits are also a major category of complaints. When will the statutory obligation to amend the PMBs be fulfilled? Thank you, Chairperson. That is all from my side for now.
Good afternoon, everybody. Good afternoon, Chair and the members, and to CMS. Thank you for your presentation. I would just like to ask a few questions. And just to reiterate what Member van Staden said about the PMBs now, when I worked in that industry many, many years ago, you know, PMBs were always a hot contender. And I think, you know, the listings in terms of the law's requirements in terms of legislation really needs to be made very clear so that people know exactly what their rights are. Then I would also like to know is when will the new macro micro structure be approved and how long will it take to fill these outstanding posts? Also in terms of, has the CMS done studies on the NHI impact on the medical schemes and what was the findings? What is the industry's feedback and concerns regarding the NHI? What are the strategic vacancies within the CMS? And please give us more info regarding the fruitless and wasteful expenditure of 64.1 million. You know, has any consequence management been put in place and what were the outcomes of that? And were there any disciplinary matters taken against officials in terms of this? Because this has been noted by the AG in terms of effective steps that have to be taken to deal with this matter, as well as the fact that statements submitted for auditing were not fully prepared in accordance with the prescribed financial reporting framework of the PFMA. And I think it's something that really needs to be taken cognizance of. And if you could just please give us how you're going to deal with this in terms of consequence management. Then I also want to, just a clarity question. Does CMS play a role in ensuring that medical aids have certain plans in place that are affordable to the end user? And how are you addressing this? Well, there are some medical aids that have, you know, affordable plans on their schemes, but not all medical aids have that. And is there any move to address this issue? Could you also please advise me what the preventative and primary healthcare PMB packages are? And I think that was also addressed by Member van Staden and of course is a very, very critical issue. Then how is CMS, sorry, no, I've asked that. One of the major challenges for medical aid users is choosing a medical aid that is affordable within their category. And does CMS actually advise people in terms of that aspect? Thank you, Chair.
Thank you.
Thank you, Chairperson.
Honorable Clerk, yes, Honorable Thembekwayo. Can I just hold for a moment? I have a burst water pipe here. Honorable Munyai.
Honorable Chair.
Can you just take for 5 minutes? I'm going to just get somebody to sweep this waterway here from here where I'm sitting and connected.
Not a problem, Doctor.
Thank you.
Honorable Dr. Thembekwayo, you may proceed, please.
Okay. Oh, thank you, and thanks for the presentation. Firstly, under the strategies to address underperformance, one of the points mentioned is to fill in vacant funded posts. My question is, can you take us through those posts and when are they advertised and filled in? How do you account to slight decrease in medical aid users in choosing a medical aid specifically due to high costs thereof? How would you influence the medical aids to check their unaffordability positions of medical aids? Still related to this question, there are some researches conducted in this department. I would like to find out whether you have undertaken a research whereby you investigate the client service satisfaction with specific reference to the costs of medical aids. If you did, can you take us through the findings and what are the recommendations thereof? And to ask if ever there are some, those articles that are published, are they published in accredited journals in South Africa or internationally so? And when it comes to table on page 45, the one that I was always interrupting the presenter thereof is, if a table is presented, the same information that she was talking about should accompany the table as written statements that explains in actual fact the table. That's why we couldn't understand what the presenter was saying, because she just put the table there and kept on talking to herself and her committee, not to us, because we couldn't understand what was there. So in future, when you put up a table, let it be accompanied with the notes that explains explicitly what the contents of the table is. Last question. I'm not satisfied with the explanation given on the notes to the annual financial statements with specific reference to irregular expenditure and fruitless and wasteless expenditure. The reasons that was given, some of them being control, investigate, and consequence management, it's not enough. Can you please revisit this area and give us more concrete reasons that we would maybe consider or accept why you had this irregular expenditure and fruitless and wasteful expenditure? Thank you, Chair.
Honorable Chirwa.
Thank you very much, Chair. My network is a bit unstable, so if I'm not audible anymore, thank you to the CMS for their presentation. I just have a few questions as well here, and the first one is about their jurisdiction over medical insurance, right? Because legislatively, it's not within their jurisdiction, as according to the Medical Schemes Act. And I want to hear from the CMS why they've gone over and above their legislative function and limitations to also regulate medical insurance. And you also see this even in their presentation, right? It's only in depth in regards to medical aids and all of those issues, medical aid schemes, and not necessarily medical insurance. But there's the same fields that they are also regulating to such an extent that even the last time we were in a confrontation with you guys in the portfolio committee over your insistence to want to phase out medical insurance first before you do medical aid schemes. And I questioned your issue of allegiance on that particular issue. But it was not responded to adequately because of the things that were happening. And you also then extended the circulars and said all of those things, right? So I want to know on that particular issue, why it is still the case when we've got insurance bodies that exist in the country that are legislated to oversee insurance. Why is the CMS that breaks their legislative jurisdiction and limitations in order to cater for medical insurance? What's the reasoning behind that? And secondly, I want to find out what is the current plan of phasing medical insurance versus medical aid schemes out in preparation of the so-called national health insurance. I just want to have an idea of and build this particular discussion as it has been ongoing for over a year now. But I want to hear from the CMS, what is the current phasing out plan of medical aid schemes and of medical insurance, and the reasoning behind that as well. If you remember correctly, the reasons that you gave for phasing out medical insurance did not suffice. Hence, you even extended and stuff like that. And even the engagements you were having with stakeholders were moving in that direction. So I want to hear from the CMS, where do things stand currently, and I'm just a bit unsure. It's unclear because it was also unclear in the AG's report on the issue of following procurement laws and regulations in regards to the CMS. What has been the trend so far in compared to last year's report and this year's report, and what are the plans to strengthen the CMS in following procurement laws? And second, lastly, I want to know if the CMS has any sponsors, financial sponsors, and if they do, can they just list them for us in the portfolio committee? And if they have any other external affiliations, also list them for us, and what the relationship in that regard is. And also just to emphasize the point made by Honorable Dr. Susan Tembekwayo, we need to categorize and diagnose wasteful and irregular expenditure properly. In most of these cases, you find that these are criminal offenses, and that's when the Doctor and Honorable Commissar Susan Tembekwayo says your reasoning does not suffice. It is actually true, because then it ends up seeming as if you are enabling the crime that is happening in the CMS, you are enabling the cash heists that are happening in the CMS, and you want to investigate yourselves over the crimes that are happening in that very CMS. So there has to be a much more concrete plan on how you are going to deal with issues of wasteful expenditure and regular expenditure, especially because in most cases, you're not even explaining them properly. So we don't know in detail what exactly you wasted money and what exactly that irregular expenditure is on. So if you can, to some extent, also appraise us on that particular issue, because this is the case in most of the departments and most ministries, right? Most of the crimes that happen in these departments are covered by the terms wasteful expenditure and irregular expenditure. So there has to be much more concrete consequences and concrete actions, especially by the executive of CMS, to see to it that whatever is happening there is not always covered by the shield of we will investigate, or there's an ongoing that never suffices in tangible consequences. And even the consequences that you give out do not measure up to the kind of crime that is. Criminal crimes and all of those crimes should end up in people going to jail, not just suspensions, because this is the money that's supposed to go to the assistance of the people of this country who pay the tax and who also make sure that the CMS exists. Thank you very much, Chairperson.
The Honorable, the Chairperson, Dr. Jacobs is back. The next person that is due to speak will be Wilson, but the Chairperson will call upon you, Honorable Wilson.
Thank you very much for holding the fort, Honorable Munyai. Honorable Wilson, you are next.
Thank you, Chairperson. And in principle, I'm covered. I unfortunately, I think along with everybody else today, have had a real struggle with network and bandwidth and all sorts of things. So there are a couple of things I did miss, but I think in principle, I'm covered. The one thing I just wasn't sure about, and I think the Honourable Van Staden may have asked this, is with regards to the S59 investigation. Into the racial profiling. If you can give some feedback on this and advise when the report will be finalized. I'm not sure if you mentioned it. I may have missed it, but in principle, Chair, I'm covered. Thank you very much.
Thank you, Honorable Munyai.
I wanted to thank you very much, Honorable the Chairperson. I think we must encourage the organization for really trying to turn organization around. Of course, there are weaknesses, but the area that I want specifically, there are two areas that I want to establish. What was the penalty by SARS for? What was that penalty about for? What is the basis? They can clarify the details why they were penalized by SARS. And I'm sure I've asked the population, the staff of the organization. I'm asking this because I'm seeing the bill for telecommunication, which is quite 6 million plus, if I'm not correct, maybe they may clarify exactly the amount, because it's only when maybe perhaps you are using the satellite communication that you can consume that bills so quickly. But you know what? The summary is that they're trying their best to turn the organization around. They must be congratulated and supported. And because if I see the comparison that they were trying to demonstrate in the organization, in the presentation, it indicates clearly that they are turning around the organization. And I'm sure each and every organization, when you try to turn it around, it takes a lot of time, and also it comes with some challenges. I must congratulate them and encourage them to work very hard. Thank you very much, Chairperson.
Thank you very much. Any other members? Dr. Kabane, I already started thanking you for your presentation and also congratulating you on your achievements. We've heard some members raise some issues where they asking for more clarity from you and from your team. We've heard of the challenges with litigation, and maybe you could give us some more explanations as to what those litigations are and the costs which you've had incurred with the litigation. Then I've heard an explanation on irregular expenditure. It was also raised by another honorable member, and of your intentions to finally eliminate any non-compliance, and it was non-compliance in terms of Section 55(1)(b), and to decrease this problem. And you've heard it also being raised, as I said earlier, by another member. What is also good is that you were able to turn your deficit around to a surplus in terms of your current liabilities. And we had seen in the past that it was something that you were working towards achieving, and it is good to see that you're finally at that point. And then I also note the support that you're asking for in terms of your financial sustainability model, and on the Section 59 investigation, and you heard some of the members talk about that Section 59 investigation, and maybe you can give us a bit more material facts around that investigation very shortly. We are already at 15:40, but I do think you'll be able to maybe provide a bit more information with regards to that. And I'm very happy that in terms of your ICT systems, you've been able to improve. And also in terms of your employment equity targets. But you have a number of questions which have been raised by the honorable members, and I'm going to give you an opportunity, you and your team, to then speak to those things. Thank you.
Thank you, Honorable Chair and members. I will attempt to answer as many questions as possible, but in the audience, I've got my colleagues who I will ask also to come in and provide a more detailed explanation. But I've also noted some of the requests for detailed reports, you know, and we've made notes of these, and we will, you know, after this meeting, put together a report where we detail all of the information that has been requested from us here. If I were just to start with the first question that was asked regarding the update on the restructuring and how that is impacted upon by the resource constraints here. Can I just indicate to the Honorable Chair and members here that the process of restructuring at CMS has virtually been completed. I think out of the 130 plus posts that exist, you know, almost 90% of the personnel have now been placed in those posts. Yes, because of the restructuring process, additional posts were created, and these are the posts that were currently in the process of filling. We have decided to do this in a phased-in approach because of the number. At the time when we migrated all the warm bodies, we had 32 vacant posts, and we decided to go in a phased-in approach, and we started with a leadership post here, because we thought if we start with the lower category posts, then if you establish units and branches that do not have leadership, and it always creates a problem. So basically what we've done, we have now filled all the executive manager posts, and these are individuals that will be leading specific branches at the CMS here. The only post that is still unfilled is the one of the executive member protection. And this is a post that we tried to fill, but you know, the recommended candidate was not interested in the amount that we're prepared to pay. So it was re-advertised, and we're in the process of finalizing the shortlist and the interviews. Our plan is to make sure that this post is actually filled before, you know, December. And then the second category of posts that we have phased in terms of trying to manage the cost related to this are the next level of posts here. And these are your senior manager posts. We have been lucky enough to recruit internally for most of these senior manager posts, but some of them have been advertised, and as we speak, we're currently filling them. For instance, today I was just signing an approval for the filling of the senior manager communications. But we can provide a detailed report that demonstrates how many of these posts were vacant, how many have been filled to date, and how many still need to be filled here. But as long as there's an understanding that we're not taking the big bang approach of trying to fill all the posts here. But I'm sure honorable members have also seen some of the adverts that we have taken out in the, you know, daily papers advertising for these posts. The other question was, what strategies are we putting in place to stem the tide of the high turnover of staff here? This process, we are told as we read that it's not just affecting CMS. We're told that during COVID, there's a phenomenon that has been noticed. It's called the big resign, where individuals would resign in a job even when they don't have an alternative, simply because their values, you know, do no longer, you know, seem to be respected by the employer. So we've put various strategies in place to try and retain staff, and this is through, you know, internal recruitment at the CMS to make sure that we don't lose people that have been there for some time. We are struggling to put together the incentives because of the economic, you know, atmosphere that doesn't allow for too generous, you know, bonuses and salary increases. But we have introduced a strategy, which is our working model. We're calling it a hybrid model, where people are at CMS for 3 days a week, and the other 2 days working from home. We believe that this will help to retain those people that have got acclimatized to the COVID environment. And it is working well for us at the moment. But yes, we are going out and recruiting and also trying to motivate those that we have here. In terms of the Section 59, Chair, I would just love to give a brief report, but we can put together a written one so that members of the Portfolio Committee can have the benefit of understanding the context and the specific actions that we're taking. I think members of the Portfolio Committee would be aware that there was an interim report that was released by the Section 59 panel. And as a result of that report, the Portfolio Committee itself invited us to Parliament with GEMS and other key stakeholders. And we were at pains to explain to the Portfolio Committee that the people responsible for the report and finalizing it are the ones that are holding the process up. Because after releasing that interim report, they asked for additional comments. And once the deadline for the additional comments expired, we've been at pains knocking at the door of the chairperson and the panel members. And up to now, we have not been given that final report. And frankly, we do not understand the reasons, because they have not said to us, we're unhappy about this and that and that. That's why we're not releasing the report. But Chair, we've taken the view that the person that we have a contract with here is the briefing attorneys that we have a contract with. And we've basically placed that briefing attorney on terms. We have even reported them to the Legal Practice Commission or Committee. And basically they are now investigating our case against this person, because we say they have failed to act in line with the terms on which they were contracted. But the ultimate aim, Chair, is that we believe at this stage, we are left with no other avenue. Having consulted yourself, and other key stakeholders, we know with the industry and the affected parties, they have signed a petition which we have lodged with the panel, still without a response. We believe that the only platform left for us is to take the Section 59 panel to court and ask the court to actually, force them to release that report and to explain why it has not released up to now. So, Chair, we're working with our legal team around that strategy. Our own council has given us blessings to move ahead, with that strategy. So that's where we are with Section 59. And we appreciate, Chair, that a lot of people are unhappy here because they expected the report to be released sooner than later. If I were just to address also the issue of the prescribed minimum benefits, why it has taken so long, what are the preventative PMBs? Yes, honorable members, in terms of the current legislation, it says that we need to revise and review the prescribed minimum benefits every 2 years to ensure that they are in line with technology developments and best practice. But at a practical level, honorable members, is that prescribed minimum benefits are a contested terrain. A contested terrain between ourselves, which want to extend these prescribed minimum benefits to cover as many members as possible, but we're sitting with schemes and administrators on the other side of the fence who say, when you increase these benefits, you affect the claims, the level of claims, and basically the financial health of schemes. So every time we wish to introduce a change in the prescribed minimum benefit, unless obviously it's something like what we did during COVID-19, where we introduced COVID-19 as a prescribed minimum benefit, and in addition, we added the vaccine. you know, under those circumstances, we received immediate support from the industry. But on every other matter that we've tried to expand the prescribed minimum benefit on, we have been challenged. But honorable members, we have made significant progress in terms of reviewing the prescribed minimum benefit. And I know one member was asking, what are these, you know, preventative and health promotive prescribed minimum benefits? If you look at the current prescribed minimum benefits, they are what we call a pair of disease and treatment pairs here. And these are about 270 in number. And then in addition, you've got another 30 chronic disease list. But most of these here are referring to conditions that, you know, have to be treated in hospital. There are a lot of health prevention and, disease prevention and health promotion measures that are not included in the prescribed minimum benefit. An example of this is your contraceptives. These are not covered, but you find that the schemes are actually happy to pay for, you know, a complication that is related to birth instead of paying to prevent. A lot of the immunizations for children are not covered in the prescribed minimum benefit. And those are the health promotion and disease prevention services that we wish to include here. And at this stage, where are we with the review? With the review is we have now looked at the health promotion and disease prevention package, which we wish to include into the existing prescribed minimum benefits. But we're in the process of preparing the final documentation that will include the costing of those additional prescribed minimum benefits we want to include. But we've also done some studies of affordability and willingness to pay. And we believe that by end of March next year, we would be able to present the minister with a set of recommendations where we say, can you phase these disease prevention and health promotion additions to the prescribed minimum benefits so that it's done in a manner that won't make the whole package too unaffordable. So that is where we are with that process here. There was a question around the strategic post. I've mentioned the executive manager member protection that is currently in the process of filling. But there's, in addition, another key post that we want to fill as soon as possible, and that is the public health specialist post, which we believe will drive some of the projects, such as your low-cost benefit option, as well as your prescribed minimum benefit. I've noted the requests around the irregular, fruitless, and wasteful expenditure that we need to clearly break it down so that it's understood, you know, what it relates to, what laws of procurement and policies were not complied with, and what actions and steps we're going to take to address these. I think this has come from various members, and they've also asked us to revisit the input that we've already made and provide a detailed breakdown here. So we will do so, and I'm sure the CFO has made notes around that, and that will be addressed here. There's also the question around what honorable members have called affordable plans, and whether we do play any role in advising potential members on these plans. I think the first question is, we as a regulator are concerned that a number of the options that sit in schemes are unaffordable. But we believe that part of the reason why they are unaffordable, it's because of the fraud, waste, and abuse that is happening in the industry. And we believe that once we make an impact on that, some of these options will be affordable, and the schemes would be able to attract more members. But I think we need to just be careful in trying to say, let's exclude the prescribed minimum benefit from what should be guaranteed in a scheme option, with the view of trying to attract as many people into the medical schemes industry. If you've got an option that does not guarantee you the current prescribed minimum benefits, or indeed what we're likely to add onto the prescribed minimum benefits, then you run the risk that after making your contribution on a monthly basis, at the time when you need these benefits, you will be told that you are not covered for that. So that's the other side of the coin that we are trying to prevent here. We are very wary of introducing and supporting options that do not, as a minimum, cover the prescribed minimum benefits, because for every scheme member, that is about the only benefit that is guaranteed, that if you suffer from it, a scheme has got no option but to pay up, irrespective of what option you have bought on. So once we introduce options that exclude prescribed minimum benefit, we're going to make it difficult for ourselves to regulate. We're going to find more member complaints, and maybe my last input on the matter is, do we advise members in terms of which option to choose? As a regulator, we can't be a player and a referee at the same time. So whilst we can provide broad guidelines to members in terms of what to look for when you are choosing, we cannot play the role of the broker by saying, take this option X instead of that one. That we leave to brokers, that we leave to members' discretion. But there was a question around whether we have conducted researches that relate to service satisfaction and affordability of schemes. I'm going to ask Michael to talk to that here, because there was a study that CMS conducted where they sought to determine what members of scheme, are prepared to pay for, what criteria they use when they are buying options in a scheme, and whether they have run out of funds by the end of the financial year, and what conditions have they not been covered for yet. So please, Michael, after I stop, I'm going to ask you to talk to that. We will provide a list of all the researches that we have been engaged in and the journals that we've published at. Michael can also talk to that as the head of research and monitoring, and basically our chief researcher here at the CMS here. Honorable Van Staden, yes, you are correct. When we come and report on the annual report, it's almost long after many events have occurred here. And I think as an institution, we are available if at any one time the portfolio committee wants to invite us to pose questions, whether it's on specific areas of regulation, like you've suggested, those schemes that you think are probably in trouble, a detailed report on Health Squared, Medipause, GEMS, and others. We are available for that kind of engagement. But the story of Health Squared is a very long one here. And if the honorable member does not mind, can I ask that we put that in a detailed report here? Because if I just give you an answer of a few sentences, a whole lot of context will be lost here. And we believe it is important to be able to cover all of that here. Yes, we appreciate that in terms of the complaints here, there are delays in the processing of the complaints, and we're trying to beef up our processes and the personnel to deal with these here, because this is often where we are found to be one team. Honorable Chirwa, your questions I am coming to now. Maybe let me start with those, Honorable Chirwa. You're asking why our jurisdiction has now extended beyond the medical schemes, and we find ourselves having some primary insurance products in our stable that we're trying to regulate here. The short answer to that here is that since the advent of schemes here, you have had products here that often do the business of a medical scheme, but sit within the insurance space. And this created a regulatory confusion as to whether should it be the CMS that regulates those entities or should it be the insurance regulators. So after long discussions, there was basically, a consultative process where all the stakeholders were called: Treasury, FSB at the time, CMS, and other key stakeholders. And what they came up with was a piece of legislation called Demarcation Regulations. And these are the regulations that basically threw all these products and said, CMS, you need to regulate these products because they are doing a business of a medical scheme, but make sure that at some point there's a framework that allows them to migrate into the medical schemes industry. So these products are sitting with us. They are non-compliant with our act and regulations, and we're exempting them and regulating them through an exemption process. And we believe that we are unhappy in that approach of regulation, because we don't think there should be regulations and then you exempt a certain entity on a perpetual basis from complying with that, that piece of legislation. So the short answer is we're busy with this framework that will determine what must happen to these primary insurance products that we're regulating under the demarcation, whether they should remain with CMS or they should be transferred to the insurance regulators. So we're finalizing a process on the LCBO, which will create that framework, and then we'll present that to our minister. And then the final fate of these products will be determined. At this stage, there is no plan to phase out anything, because yes, we issued Circular 80 and 82. And basically that was more a warning to these primary insurance products to say, can you change the way you're doing your business so that you are more aligned with the Medical Schemes Act? Otherwise, we're going to have a problem. But because we've started a consultative process, I think all the stakeholders must just now be patient, because we're at the tail end of that process. And within the next 2 to 3 months, we will be able to come up with all the recommendations that will be based on all the inputs that we've received from all the stakeholders. And this will determine what happens to schemes. This is, and also what's going to happen to these primary insurance products here. So the reasoning behind it is that you're correct here. We are a creature of statute. We regulate in line with the Medical Schemes Act and regulations. And we don't want to regulate anything that doesn't fall within that ambit. And we believe that when this process is complete, the entities that we regulate must be compliant with the Act. I hope I've tried to give as much detail as possible. On your question around the policies on procurement, what has not been complied with, I think it's linked to also your question around the categorization of fruitless, irregular, wasteful. You want to hear our plan. You want us to talk about the criminality and the consequences. I think the CFO has listened to all of that, and we will be able to provide a detailed explanation. Yes, you've asked us if we've got sponsors from outside. You'll see in today's presentation, there's a slide that is a pie chart that talks to our revenue. And the 90% of our funding comes from the levies that we collect from principal members of schemes. And these are about 4.1 million of them. The rest, it's interest accrued. The rest is what we charge on accreditation, but we also get a grant from the National Department of Health. So that's the start and the end of where we get our funding. But we can also provide a list, as you've asked. The external affiliations at this stage, you know, apart from CISNA, which is a SADC body that we belong to with other fellow regulators, we don't have any external affiliations. Honorable Wilson, I think I've covered the section 59. And Honorable Munyai, I think the CFO has listened to your question around the penalties on SARS, and she will respond. But you also had a question of why we spend so much on telecoms during COVID. You mentioned a figure of around 6 million, and I'm going to ask that our CIO, who is part of this meeting, to just explain the items on which we spend during this period in order to make you know, employees as well as council members ready to operate under COVID environment. But I'm sure the CFO can also break it down in terms of expenditures. Honorable Jacobs, you've also asked for us to give you a detail of the litigation costs. Yes, these are being reduced, but I'm sure we can still give you a list of all the relevant cases, what the issues are, and what we're paying to these here. But we also note the positive comments and words of encouragement here. I'm going to ask Michael to maybe start and talk to those research questions, and then followed by the CFO and the CIO in that order. Thank you, Honorable Chair.
Dr. Kabane, thanks for the good responses, but we also need to just note a bit of our time management, please. Thank you.
So, yeah. Colleagues, please be brief. Thank you.
All right, no, thanks, Doc, and thank you, Chairperson. I'll also be brief. So the first question around the platforms where we publish our research papers, it varies really. I think it's a combination of peer-reviewed journals, and then it will also include academic in the main, but sometimes there are publications that share information, like for instance, the World Medical Journal. On an annual basis, I think we publish at most 2 articles there in the World Health Medical Journal. So it really varies, but in the main, they are on peer-reviewed journals. We've also done a chapter in a book called Healthcare Book. It's a UK-based editor. So to answer the question, in the main, it's on peer-reviewed journals. So in terms of the other surveys, we have done a number of surveys. We have done a survey on patient experience of care. That is also in the public domain. It's on our website. We can make that report certainly available. But the main finding of that report is that because it was mainly based on patients diagnosed with diabetes, from the trying to understand what are some of the gaps insofar as disease management programs are concerned. Family integration in a disease management program came out as one of the big limitations. So it will be addressed through the accreditation process, as also monitoring and evaluation of a disease management program. We've also done a study on the benefit richness, which was looking at to what extent do members of medical scheme run out of benefit. This report will also make it available, but one main finding of that report was that 44% of members of medical schemes that were surveyed indicate that they ran out of benefits in the past 12 months, and almost 50% of those had to pay out of pocket. So the recommendations of the report will filter through to a benefit approval process within the PMU unit within CMS, and then so those reports certainly, Chair, we can make them available. Like I said, they're in the public domain, and then we'll certainly make them available to members of Parliament. Thank you.
All right, thanks. CFO? CFO, we can't hear you. I think you're on mute. Oh, I see the CFO was kicked out. She is just now rejoining. Maybe the CIO, Mr. Clark, can you just talk to the expenditure on the telecoms during the COVID period? What key items, we spend the money on, and if you are aware of the amounts, you can just explain them to Honorable Munyai.
All right, thanks, Registrar and honorable members. The cost on telephone are mostly for data cards and devices, cell phones. And this were during COVID or with the remote work, just for us to be able to enable our employees to be able to work from home. So we then got each and every employee with their laptop associated with a data card to be able to connect and be able to work remotely. But we have seen, and I think this is on one of the slides from the CFO, that the costs are declining now because we are now working from the office, mostly 3 days in the office, 2 days at home. So we will be seeing the decline of those costs, but mostly, Honorable Munyai, these were costs that were related to data cards and being able to access the internet working from home. Chair, thank you.
All right, thank you. CFO, are you now in?
Yes, Dr. Kabane, I'm in. Apologies, I had to change devices. Battery died.
Okay. I hope you've heard all the questions. Please go ahead.
Yes, there was a question asking about the SARS penalties, what those relate to. So what those relate to, it's basically a VAT, the penalties related to VAT on imported services. Sometime last year or year before, SARS requested a number of documents dating 10 years back from CMS. And they, especially when it comes to imported items, like if you're buying subscriptions from overseas. So they were asking for those kinds of documents. And then there was a mini audit conducted by SARS. When they came back, they said, these are the non-VAT vendors that CMS has been making use of and has not been paying VAT. And as part of the VAT Act, if there's a non-VAT vendor from abroad, we need to pay VAT on behalf of that vendor. So the penalties and interest therefore relate to that portion of VAT that we should have paid dating years ago when we got those services. Those services, for example, at that point in time, there was Microsoft was not a VAT vendor, they are now, and other suppliers from overseas that we're using as part of our ICT infrastructure. So what we did when we got that communication from SARS, we did pay the principal amount. However, when it came to the penalties and interest, we requested that SARS please pardon us and write those off. Currently, if we are using, and we seldom use any of the non-VAT vendors, international suppliers, we do pay that portion over to SARS. That's what that relates to. And when it comes to the makeup of the irregular expenditure, where it comes from. This comes from years back, and we're still experiencing the impact mainly of that irregular expenditure. It's basically a panel of lawyers and investigators that was not constituted properly in terms of the proper SCM processes as legislated by Treasury. So we've been making use of that panel, and we stopped making use of that panel when we identified that it was irregular, and we do have a proper panel now. However, the cases that are still being investigated by those law firms are still continuing, and therefore we are still incurring expenditure based on those cases. We have had discussions with Treasury where we asked if we can transfer the cases to the properly constituted panel, and Treasury said no. What we therefore need to do is to just, as they finish the work, close off that contract and apply for condonation or a recovery, whichever way it is when it comes after the investigation. There is that, and there was a point being made by one of the honorable members that we are investigating ourselves. Not necessarily, honorable members, there's no wrongdoing that we are hiding intentionally within CMS. The Loss Control Committee is looking at the cases of fruitless and wasteful and irregular expenditure. However, where there are cases that need to be reported to the police, CMS has reported such cases to the police, and we do have case numbers where we've reported such and we've made Treasury aware. Where there are cases that need to be looked at by SIU, SIU has looked at those cases and so forth. So when it comes to any wrongdoing, we are not pardoning any wrongdoing by CMS that is being investigated properly. I don't know if there's anything else, Dr. Kabane, that I possibly missed.
Yeah, I think you've covered most of it, but we promised the honorable members that we'll break down the irregular, fruitless, and wasteful, categorize it clearly, indicate, what policies and laws were transgressed, indicate the amounts and the progress towards investigation and applying consequences. Okay. So I think we will need to produce a report that talks to that. But Honorable Chair, I think we've covered most of the questions. Thank you, Chair.
Thank you, Dr. Kabane and the team. We appreciate you answering all of those questions. If there are any which have not been answered, you're welcome to write to our committee secretary. Honorable members, we've come to a break in our meeting for this afternoon. We will be receiving a presentation from SAPRA at 1700 hours. Dr. Kabane and the team, maybe you yourself, Dr. Kabane, want to say one last closing remark. You had 2 requests which you had given to us. Maybe just on that very shortly, and then we will take that break.
Right, thank you very much, Chair. Let me just, I see there's a hand, Chair.
I notice the hand of Honorable Clark.
Thank you, Chairperson. I just want clarity. We were told within the answers that, cheaper packages of medical aid might result to PMB packages not being paid, PMB conditions not being paid out. Chair, that's why I want clarity, because if you take a medical aid like Discovery, for example, they have a plan called Key Health, which is their lower option. And I think it's sort of, financially carried through by the higher plans, but they certainly pay out on all the listed PMBs. So not all medical aids that are cheaper packages don't, then you don't qualify for a PMB case. I just wanted to raise that. Thank you, Chair.
Yeah, Chair, if I can proceed.
Yes, please, just short remarks, and then we're closing. Thank you, Dr. Kabane.
Yeah, thank you very much, Chair. I'm not going to say long, except to say that we really appreciate the comments and the advice that we've received from the honorable members. And Chair, yes, we will still come back to you and engage on the sustainable financial model and update you so that where it is possible, the committee can assist us in making sure that we achieve that sustainable model. But we appreciate the engagement and we will provide the reports as required, Chair. Thank you very much.
Thank you very much. Honorable members, don't switch off your devices. We will be back at 5 minutes to 5. We'll start promptly at 5 o'clock with a presentation from SAPRA. Thank you. You may leave if you so wish, Dr. Kabane and team. Thank you.
Thank you, Chair.
Honorable Geller, I see you've raised your hand. We just start this meeting.
Yes, Chairperson, my hand is up.
Okay.
But after the presentation.
All right. Honorable members, we've had a short break. This is still a continuation of our meeting of this morning. We're about to receive a report from South African Health Products Regulatory Authority. We have on the annual performance reports, and we have on the platform, we have the chairperson of the board, Professor Ellen Rees, and we have the CEO, Dr. Tumi Semete, and they probably have some other members with them from their board, and the CFO, etc. We will continue where we had left off. I'm not going to read the rules again because it's still the same meeting which we are, as I mentioned, we are continuing with. I will hand over to Professor Rees to make some remarks and to introduce the team. And we'll go straight to the presentation. I see that Dr. Semete has already been made a co-host. Thank you.
Thank you. Yes, Dr. Semete is with us. Dr. Jacobs, honorable colleagues, thank you very much for this invitation. We look forward to having discussions with you, and I know that our discussions are always quite probing, and we appreciate that. I will introduce at the end the other board members, and I'll ask Dr. Semete to introduce her colleagues. But perhaps just by way of introduction, on this occasion, I was reflecting back to the first time that as the SAPRA board and the executive team came to Parliament in those days, pre-COVID in person, you gave us a real grilling because we had qualified audits, we had a host of things that needed to be done. And I think that this time round, I really do want to acknowledge the work of Dr. Semete, her team, and my fellow board members as well, because they've achieved the World Health Organization rating of what's called maturity level 3 for vaccines, and for one aspect, maturity level 4, and 4 being the top, but Dr. Semete will explain this more to you, but that is a real recognition from the World Health Organization that we have a competent functioning regulatory authority, and it also is going to give us the status to really support the ambition of having vaccine manufacturing, for example, and pharmaceutical manufacturing in the country. But it also tells us we have reached a benchmark, which is very good, and we can talk more about that. The second thing is that we got an unqualified audit. Indeed, there were, as you'll see in the presentation, there were things to be corrected and done. And to the CFO and his team, I think that this was again a real achievement from just a very few years ago when we came that first time. And then the backlog, which we talked with you about many times, we're now 99.5% through that backlog. We hope to finish it at the end of this year, and that will be a huge breakthrough. That's the good news. The bad news would be we don't want to create another backlog. So these are the things that we can talk more with you about. I also want to just acknowledge that Dr. Semete and her executive team and the whole team were awarded from Science and Innovation a top management award. Because they really have been outstanding, and it was particularly for their work during COVID. And so I want to also acknowledge that I think SAPRA has functioned extremely well during COVID and has made some very significant, really did things in a very disciplined way. And in some cases, I would say really outstripped some of the very well-resourced global north regulatory authorities in the way they went about their business and the decisions made. So again, a breakthrough. But clearly, you'll see in the presentation, we're not 100%, we're not green in everything, and we'll have that discussion. So if I may introduce my colleagues who are here, I'll introduce Dr. Smete last, and she'll introduce her colleagues. So we have Mr. Taba, who is a board member, and she is chairing our HRMCO committee. We have Hanley Mayer, who is a board member, but also chairs the ministerial committee that looks at vaccine safety reports as well. Just hoping I don't miss. So we have Joyce, who is Joyce Soka Gugweni, who is a member of the board. Mandisa Tlengwa, who's Mandisa Skosana, who's a member of the board. Obakeng Masondo Obasinkaoli, who is the deputy chairperson. We have Patrick Mana, who is a board member as well. Lani Ngobesi, who is a board member who is appointed to the board for governance reasons. Zintle Makatini, who is a member of the board, appointed the board in her capacity as a senior laboratory scientist, but with a lot of knowledge in this field. I hope I haven't missed others out. So we have a number of board members. I'm sure others will join us, and I'll ask Dr. Smete to take over and introduce her colleagues. Thank you.
Ellen, shall I say Itania?
Oh, sorry, Itania, did I miss you?
Yeah, sorry, I'm using my son's laptop. So
oh, okay. So this is Itania Mashao, who is the he is the chair of what we call the Technical Operations and Regulatory Science Committee. It's a board committee, a pharmacist by background, but that committee looks at all of the technical outputs of the board and oversees the strategy in terms of the technical component of SAPRA. Thank you very much. I'll hand over now to Dr. Smete. Thank you.
Thank you very much, Prof. Rees. Good afternoon, members, and thank you for making the time to engage with us on our 2021-2022 performance report. I'll introduce my colleagues, and if they can maybe just have their cameras on, just so you see who is the team that's been supported by the board in executing the regulatory function. I've got our CRO, Chief Regulatory Officer, Ms. Poshan Gambule. I have our CFO, Mr. Rachad Khos. I have our executive for HR, Mr. Gordon Takati.
Thank you, CEO. I'm load-shedded.
No worries. Thanks, Gordon. And our COO, Ms. Kristalna Reinecker, there she is, as well as our board secretary, Ms. Nazreen. Great, thank you. Thank you. Chair, that's the SAPRA team.
Thank you. You can please continue with your presentation.
If I may just introduce Lerato Matai as well, a board member who chairs both the governance and the finance committee. Thank you very much.
Thank you. Again, members, thank you for seeing us and meeting with us this afternoon. So as I've mentioned, we're going to be giving an update on the 2021-2022 financial year. So that is the prior financial year. We're going to go into quite a bit of detail in terms of the environment that we are operating in terms of our response to COVID and how we supported the country in this regard. We'll go into a bit of a deep dive into how we have performed in the respective areas of the organization. Then we'll end off with an HR as well as a finance presentation. But before I can do that deep dive into the prior financial year, I think it will be remiss of us if we don't highlight these, and Prof. Rees has already shared these with yourselves, and some of you may have seen this in various reports and various media platforms. But we're quite thrilled to be able to have, since SAPRA was established about 4 years ago, to be able to have an unqualified audit opinion for the 2021-2022 financial year. And you know, this was really on the hard work that the team put together to make sure that from a governance perspective, we're compliant, we have the required internal control mechanisms to ensure that you can trust the information and the performance of SAPRA. In addition to receiving this unqualified audit opinion, we've also been ranked by the World Health Organization as having achieved a maturity level 3. And I'll spend some time in this coming slides in terms of what this means in the global context, but also in the context of, you know, the country and all the discussions that are happening around vaccine manufacturing on the continent. And more specifically for the lot release function, we got the highest maturity level, which is maturity level 4. And this speaks to the quality of our regulatory oversight for vaccines, not only COVID vaccines, but all vaccines that are available in the continent. We are the first regulator to achieve ML4 for the lot release function, and we are the second regulator on the continent to achieve ML3 for vaccine regulation. And as we are working on these areas, we've also focused a lot of our efforts on clearing the backlog. This is a backlog that the committee is quite familiar with. It's a backlog we inherited when SAPRA was established from the MCC. And as at September 2022, we're sitting at about 99.5%. And the intention is that we will complete this project by November. And again, a lot of hard work went into this. And I'll speak to that in a bit more detail later. But I would really like to commend the SAPRA board, commend the SAPRA staff. Some of them are not even here. Many of them are not even here, who have really rolled up their sleeves in this current financial year to ensure that we achieve these really excellent outcomes. We have spent time as a regulator just reflecting on who we are, what our mission is, and what our values are. And I just want to focus really on our vision. And you will see this come through quite a bit as we present, in that our vision is that we're an agile and a responsive African regulator. This was tested to the extreme really with COVID. We needed to ensure that we're responsive to this public health emergency, and that we also implement approaches that are agile, yet still of regulatory rigor, a strong regulatory rigor. We are an African health products regulator, and we particularly highlight that because we acknowledge and really want to strengthen our role as a regulator on the African continent. And we're quite excited about the developments with the African Medicines Agency. I understand that South Africa is quite close to signing and ratifying the treaty. And this is excellent for us because we can actively participate in the structure of the African Medicines Regulator, but also strengthen our role as we participate in the continent. We also want to be globally recognized, and this was demonstrated by having this maturity level outcome by the WHO, which then says that we're a credible regulator that then enables access to safe and effective health products. As I've mentioned, we've been in existence as SAPRA at the end of the 2021-2022 financial year. It had been our 4th year. So I'm really quite happy with our performance to date, considering where we come from, considering what we had to put in place. If you remember, when SAPRA was established, we had to set up an HR team, we had to set up our own finance team, our own quality management team, all the support in essence. Everyone in our support function is relatively new, and we had to ensure that we strengthen the work we do in our regulatory function. And I'm quite happy indeed to be able to have achieved what we have in the 4 years. And I think better things are to come from SAPRA, and we're really heading in the right trajectory. And while we were doing all of that, we had to ensure that as a regulator, we support the national response to the pandemic. It was a very difficult time for all of us as regulators. It was a difficult time for all countries. We sat in positions wherein there was new information emerging almost at times literally every day. And so we needed to ensure that we are decisive in making decisions, but also that our decisions needed to be evidence-based. And so it was important that we base our decisions on science. Again, as we authorized vaccines, some of them that were evaluated in the country, some not. We needed to make sure that we look at the scientific data that's been made available to us. We authorize on the basis of that data, but also to ensure that we continuously monitor any adverse events following immunization. And I'll go into a bit more detail also around that. We had to really be agile and develop a mechanism for emergency use authorization. When it comes to the maturity level 3, there's about 4 levels. 1 and 2 indicating that there's still some gaps with your regulatory system. Either there are some systems that are not in existence, indicating that some areas are partially implemented and that you are reactive in your approach. A number of us regulators across the world are striving to be maturity level 3, and that means that you're a stable regulator, you are well functioning, and you have integrated regulatory systems. This is a maturity level of the bulk of regulators in the developed countries, and on the continent we have this only for 5 regulators now with SAPRA, some for medicines and some for vaccines. And as I've said, for vaccines, we are one of the 2. And the intention is that with time, one then strives to become maturity level 4, but there aren't many that are at maturity level 4. One that has been formally assessed by the WHO is Singapore. And for vaccines, they've been awarded the ML4 status, but you have other very strong regulators that have not even achieved maturity level 4. So really, if you consider what this means at a global level, it's that we are among the best across the world. And what it says then, it says products that are made available in the country are compliant with quality, safety, and efficacy. But also it says, as conversations are taking place and there's a lot of efforts and investment into vaccine manufacturing, that any vaccines that are manufactured in South Africa that would have a SAPRA authorization that would be released by our control lab can therefore stand scrutiny when they're considered from a quality, safety, and efficacy. So these vaccines can be made available across the world. And this again is great, not only for SAPRA, but for the country as we are supporting all these manufacturing initiatives. With that context, we operated in a service delivery environment wherein we focused on health products registration. And we had to implement a priority review pathway for COVID-related products, but also we do have a priority review pathway for the priority health areas such as HIV and AIDS, tuberculosis, as well as oncology. We also worked very hard to ensure that we are able to reduce the timeframes, particularly under a public health emergency. We needed to ensure that we reduce the timeframes by being more efficient. We've put more resources to some of these programs, and that's how we were able to reduce the times. I've alluded to the backlog that we've implemented a number of re-engineered processes to ensure that we can reduce the backlog. And while we were able to achieve what we have, it's been a very challenging period for us from a financial perspective. I think we have indicated in the past that the allocation from the National Treasury continues to reduce. We are, yes, aware of the very difficult fiscus that we have. We are in the country with a very tight fiscus. And while that is the case, I think it is important that the regulator is adequately capacitated so that we can ensure the quality and the safety of health products made available in the country. An important function that we oversee is what we call post-market surveillance. So this means that when the products are out in the market, we need to monitor them. This again is an area where we're undercapacitated. We need to ensure that, you know, as we apply these review pathways, such as reliance, etc., we strengthen this function, and I'll speak to this later, wherein I give you a sense of the amount of outreach and the amount of reports that we have seen, wherein we were notified of falsified health products that we had to go and assess. And that is quite critical. And for vaccines, we needed to ensure that we strengthen our lot release function. We have implemented a Med Safety app, and this is what the public has been utilizing to report any adverse events following immunization. We have a page on our website where we report on these every 2 weeks. And we're not only using the app as a platform, there is a paper-based format for those areas wherein app usage is not as wide. And they can then report these adverse events following immunization through manual processes, and we would then still capture that. We needed to ensure that as a regulator, we work, you know, quite hard in ensuring that we communicate to the public, particularly around COVID-19 vaccines. And a number of you have seen us in a number of platforms wherein we were engaging the public. We must say that, you know, that the period of COVID has been quite challenging for us. There were times when our mandate was challenged through public protest or political pressure. But it's important, and we continue to say that as a regulator, we will make our decisions based on scientific evidence and nothing else. And if that data provided to us is not satisfactory, we will not concede to any pressure. And we've seen this work well for us, in that we were able to make decisions that would stand scrutiny, but also decisions that when you look at other regulators have made similar outcomes. So it's important that as a regulator, we really are protected, and that we are enabled to execute our mandate, which is very much around the safety, the quality, and the performance of health products. In this regard, we also faced a number of litigations that were brought against the regulator. And similarly, we have stood our ground to say we will make science-based decisions and make sure that whatever legal challenges we encounter do not disrupt our operations too much. We have, as Prof. Rees has indicated, a board that was appointed, a newly appointed board in September 2021. Some of the members are new members, and other members served in the inaugural board of SAPRA. So we do have quite a good complement of continuity and understanding of the regulator, but also quite a good complement of new ideas, new thoughts, etc., being brought into the SAPRA governance. And these are board members, and some of them have been introduced and are present with us today. As we consider the external environment and we work closely with our board, our staff members are quite critical. We need to ensure that we continue to set SAPRA as a high-performing organization. We've had a number of engagements with our team. We have a number of planning sessions, of strategic sessions, tactical planning sessions, wherein we really engage on the business of the regulator and say, how are we going to execute our work? We also have been working quite hard to retain the talent that we have, but also to recruit new talent. We have been able to successfully transfer all the employees that were at the Department of Health under the MCC to be fully transferred to SAPRA. If I could just focus again on COVID, just some highlights around this. We were able to reduce the time that it takes for registration of vaccines from 20 months to 3 months. And how we were able to do that was through working long hours, but also redeploying some of our team members to support this area. We were able to conduct inspections in a hybrid and at times in a remote manner during the lockdown period when our inspectors were not able to travel. For those products that were unregistered, we were able to authorize those within the required time period. Clinical trials was also an important area. You are aware of a number of clinical trials that took place in the country, not only for vaccines, but for therapeutics. Some of the researchers in the country were part of global clinical trials, and SAPRA needed to ensure that we have regulatory oversight over those clinical trials. To date, we have authorized the Covishield vaccine, the Pfizer and Janssen. Those are the two that are currently available, but we've also authorized Sinovac, Sinopharm, as well as CoronaVac. We rejected Sputnik V on the basis of the lack of scientific data. We are currently reviewing Sputnik Light, and that's in process. We also are reviewing the pediatric formulation of the Pfizer vaccine. We've been able, as I've indicated, to support a number of clinical trials. We also have been able to, from an assessment of any adverse events following immunization, we've been able to do quite a lot of work to educate the public on that, to review the reports that we receive, and to do what we call causality assessments, and I'll speak to that quite soon. We also were able to register a number of antigen tests, of antibody tests, as well as molecular tests. These are the PCR tests. So all of the tests for COVID have had to go through SAPRA for their authorization. We were not going to be able to do what we did if we worked in silos. We worked very closely with many partners, with many regulators across the continent. We participated in workshops that were hosted by the WHO. They invited some of our members to be part of a collaborative review process. We are also a member of the biggest association of regulators across the world, being the International Coalition of Medicine Regulatory Authorities. We are one of the 2 African countries that are part of this. And this is where we really meet and we engage on the pertinent regulatory matters. We also play a very active role on a number of initiatives on the continent, such as the African Vaccine Regulatory Forum. So I'll now deep dive into our performance, and to say that in the last financial year, so this is 21-22, we were able to achieve 65% of our targets, and we could not achieve 9%, and 35%. I'll talk to why we didn't achieve those. From what we call Program 1, which is where our leadership and our support functions sit, we were able to meet our target for revenue. Digitization remains to be an important element. And again, this is an area that does need quite a significant amount of resourcing. And we have not been able to successfully secure funding from National Treasury for our digitization efforts. And we've subsequently have engaged with other stakeholders to ensure that we can digitize our operations. The other important thing from an IT perspective is security of information. We do sit with important information of industry and the sector, and we need to make sure that it is adequately protected. So we do conduct a number of penetration tests and security assessments. From a communication perspective, as I've indicated, we've had a lot of radio and a lot of TV interviews. This is a picture of my colleague who was on ENCA, Ms. Daphne Fafudi, whose area focuses on regulatory compliance. This team was extremely busy. Anything that was reported to us that was non-compliant, her and the team would go out and investigate that. And we also have a whistleblowing facility wherein a number of these were reported. But we ensured that we engage with the public through various mechanisms. We also took part in various radio stations to ensure that we cover a wide spread of our indigenous languages. And we even have focal points in the organization of individuals who can speak specific indigenous languages to then engage through those platforms, wherein we have videos for infographics, etc. We've also translated those into a number of the official languages. We've also contributed to scientific information and data wherein we were co-authors on a number of publications. And as a regulator, this is quite important because also we have our staff members, some of them who are studying towards their master's, towards their PhD, and this becomes important. But also it's important for us as we operate in the global sphere that we do contribute to knowledge in this area. We've also participated in a number of conferences. A lot of them have been virtual, but where we can engage and attend these conferences in person, we then do so. I've spoken to some initiatives around our staff, and one of them is around training. We are cognizant that we have to ensure that we continuously invest in the training of our staff. We've been fortunate in being able to raise funding for us to host training. And again, because a lot of these were held virtually, we were able to do a lot more than what we typically do, but we were also, where feasible, we're able to have these training sessions held in person. In this picture, these are some of our clinical assessors that had gone through a training for clinical assessors. It was for the South African regulator, participating together with the Nigerian and the Ghanaian regulator. As I've also alluded to this, it's, for us, we are understaffed. So there's a big focus on ensuring that we fill vacant positions within budget. We've engaged also with the National Treasury on this to see if they can increase our allocation so that we can bring in more, we can fill a number of these positions, because we've done an assessment that indicates that for the size of our staff complement, when you compare that to the number of applications that we have, we're just undercapacitated. And you can imagine that is not the ideal situation to be in, because you will then not be efficient. The wellness of our employees is also important. And so we launched the ICAS platform for employee assistance. I'll now go into the KPIs, and I'll talk to the ones that we could not meet for the various areas, and this is for leadership and support. If you remember the prior year, which was 2021, we had a qualified audit opinion, and as we've reported for the 2021-22 financial year, we have now received an unqualified audit opinion. We were able to meet all our other targets as indicated here. From a human resource perspective, we've implemented a number of change management interventions, which we were able to deliver on all of them. Our workplace skills plan to implement training, and for those positions that we budgeted for, we were able to fill 96% of those. And again, the constraint here is really the budget. So we work within what we are able to budget for, and it would be good to increase this number. I've alluded to digitization, that we've really struggled with raising funding for this area, and we've gone out with the executive team to see where else we can secure funding, as we were not successful with the National Treasury. I'll go into some of our core business areas now. So that was support and leadership. In terms of the backlog, I've indicated that this is a backlog that we inherited when SAPRA was established, and we are expecting that this backlog will be completed at the latest in November. And great effort by the team. Again, we had a lot of support from other regulators. We had support also financially from funders, and there was also a contribution from National Treasury for this project. I've already mentioned the maturity level, so I'm going to skip that one. And in terms of health product authorization, at the time that we were reporting for this, which is the 2021-2022 financial year, we had missed our target. But you can note that we've really put in a lot of work and effort to ensure that we clear this backlog. And that's why already in Q2 of this year, we're able to then report that this backlog will be cleared. So we had a very dedicated focus to clearing the project, and we implemented re-engineered review pathways, and that's what could enable us to clear this backlog. The other area that we track is around the registration of new chemical entities. So these are what we call originator drugs. So this is the first typically in market. There would not be any generics that are available for that. We've been able to finalize on those within the time frame of 590 days. Generics is then where you have an alternative to the new chemical entities. While we're still struggling with this area, we were able to meet our target there, but we need to also ensure that we continuously implement re-engineered review pathways. Quality management systems, we've exceeded that target, and we're quite happy. I mean, even the WHO said this is now becoming one of our strengths. It's a small team, but that works really hard. They were brought on board in 2020, 2021, and have really entrenched a very strong ethos in the organization around quality management. We're still undercapacitated for the size of the regulator that we are. So going forward, this is an area that we need to strengthen, particularly as we work towards reaching maturity level 4, towards having ISO accreditation, etc. In the previous financial year, which was 2021-22, we had not met this benchmark, but again, because we had concerted effort, you know, the team worked really hard. We then in Q2 of this year are able to report that we have met the maturity level 3. From a inspectorate perspective, I mentioned that because of lockdown, we were not able to conduct all our routine inspections. And so we conducted a number of virtual inspections. At times, we also conducted joint inspections. And what helped really with virtual platforms is that you could conduct inspections with some of the top regulators in the world, such as Health Canada, the European Medicines Agency, and they invited SAPRA to these inspections. And it speaks to the stature and the capability and the quality, excellent quality that we have of inspectors. A lot of our inspectors are also invited by the WHO periodically to join them on inspections that they conduct in other countries. So I think this is an area where it certainly is our strength, but we have to increase the numbers in this area. The area of law enforcement, whenever there is non-compliance to the Medicines Act, I've alluded to it. We work closely with the South African Police Services, wherein we have, you know, through them made arrests and prosecutions for individuals who have contravened the Act. And a lot of the contraventions we saw, they were around illegal importation of products. So what we've also done is we've put SAPRA staff at the ports of entry. So far, we've put them at the four or five big ports of entry. We need more people in that area. But also we saw some illegal manufacturing that we were able to deal with, and we continuously address this. These are some of the pictures of products that we either would have confiscated or destroyed because these were non-compliant. You will see that there are what purports to be COVID-19 tests, and these would not have gone through SAPRA. And so we were able to intercept those before they could, you know, get into the country. You see also we have some masks that were being destroyed. So there's a lot of such activities that we were able to intercept. The other area within regulatory compliance is the area of cannabis. And again, just to stress that this is when CBD, THC is utilized for medicinal purposes. All the other applications do not fall in the scope of SAPRA. So in the past, when before the schedules were amended, hemp would come to SAPRA, but it no longer does. And that has all been transferred to the Department of Agriculture. So what you see here is what is for medicinal use. We do issue licenses for those who are manufacturing cannabis for medicinal purposes, and a number of them are exporting into the respective countries that I have indicated here. We currently are sitting with about 307 applications. We've been able to issue 56 licenses, and 67 will be issued quite soon because we have finalized the resolutions on those. And also just to show you that we have quite a good spread across the country in terms of provinces that are applying. I've mentioned the challenge around conducting inspections during lockdown. We saw the impact thereof on issuance of new GMP and good wholesaling licenses, and therefore we missed our target, but we do anticipate that in future we should be able to meet this target. We also have limited resources, as I've indicated, in this area. We've been able to meet the other targets. From a clinical and pharmaceutical evaluation, I've alluded to that we implemented the Med Safety app, which is not only used by SAPRA, but it's used by other regulators across the world, the MHRA in the UK, the FDA, Ghana FDA, Nigeria, NAFDAC in Ethiopia, and a number of other African countries. So this is a platform that is well accepted in the regulatory sphere and very, very easy to utilize and report any adverse events following immunization. The intention is that we will then roll this out to other therapeutic areas. In this area, we did struggle quite a bit. If I look at the area of Section 21, we did have some technical challenges there that led to us not meeting that challenge. We were also under-resourced. We have subsequently appointed more staff members into this area and have also addressed the challenges with the digital platforms. The clinical trials have indicated that this has gone well, and this was enabled really through redirecting of our team and working very lengthy hours by our staff members. On reports for health product signals, again, we were inundated with reports. This is another area of pharmacovigilance that we want to strengthen. If I could make an example, the MHRA in the UK, the size of the team they have in this area of pharmacovigilance is about 60 individuals. At SAPRA, we only have 5 individuals in this area. And we know that the reports that we receive are in terms of numbers are quite comparable. So we are severely understaffed in this area, and we'll be working hard to increase capacity. We continue to have a number of webinars to educate the public really on reporting any adverse events following immunization or any safety matter regarding to a health product.
Hey,
Norman, I think
you
you
ask that person to mute.
Thank
Please.
you.
Thank you.
In the area of medical devices and radiation control, again, this is an area that, you know, particularly at the beginning of the pandemic, we were quite busy. We had to put in place mechanisms to ensure that we've got good performing diagnostic tests for COVID. And, you know, we put in place mechanisms that ensure that we can do our own assessment of the quality of the diagnostic tests in the country. We work very closely with other stakeholders such as the NHLS in this regard. We also are participating very actively in co-chairing the African Medical Devices Forum. And again, this is quite a great platform for SAPRA to be able to lead. We're also part of the WHO Global Model Regulatory Framework Working Group for Medical Devices. So this is a global team that develops regulations as well as guidelines that for the WHO that are then used by various member states. In the area of radiation control, we have been engaging with the Department of Minerals and Energy, as well as the National Nuclear Regulator on a co-regulatory framework. In this area of medical devices and radiation control, we were able to meet some of our targets and some we missed, particularly the one pertaining to guidelines. And this is because we still needed to have the regulations finalized and then published for implementation. And that process took longer than what we had anticipated. And we continue to work on that, and we anticipate that they would then be published quite soon. The other KPI that we missed was around the co-regulatory framework with the NNR, and they've had changes in leadership at the NNR that has led to delays in some of the work that we had started with them, but we do hope that we'll see some improvement with time. And then just to reflect on our HR, as indicated, we'll now go to HR and finance. Overall, I think from a transformation perspective, SAPRA is quite a well-transformed organization. We do have the majority of our employees at 61% being females, and these females being largely in the professional qualified areas. And, you know, what you see in terms of these demographics is typically what we would see in the health sector, particularly with the types of skills that we've been largely recruiting around pharmacy, etc. For medicines. This is the profile. What we have also put in place is our employment equity plan for the 2022-23 financial year. And we will be targeting the area of ensuring that we do recruit individuals with disabilities wherein the work does accommodate that, so that we are compliant with our equity plan. I'm now going to hand over to the CFO to take us through the finance slides.
Thank you, CEO, and good afternoon. The table shows just the progress made from 2018-19, the first time SAPRA was audited, to 21-22, from 3 qualification areas to the unqualified audit we achieved in 21-2022. A significant reduction in revenue findings specifically, which was one of the challenges we experienced historically, was seen, and the majority of our irregular expenditure was also detected internally by SAPRA and disclosed. We've also made good progress in reducing the overall balance for irregular expenditure year on year through condemnations obtained from the National Treasury. So the next 2 years, our target is to obtain a clean audit, focusing on the material non-compliance areas in terms of procurement, AFS adjustments, and revenue management. On the next slide. Just waiting for the next slide to show. Thank you. So on the audit report, the main action items or corrective measures we need to implement going forward is on the financial statement adjustments. Basically, we had 2 material adjustments during this audit, one relating to the commitment note prior year figure, and also services in kind, where it was advised to split the classification between backlog and services in kind expenditure in our notes, which was made. Going forward, the corrective measures is just to perform data validation checks as provided, and to calculate the correct totals before disclosing the financial statements together with detailed reviews. The services in kind are agreements with third parties just to obtain the supporting evidence that would be needed by the Auditor General to audit and to ensure accuracy of that information. And also then to perform detailed reviews against the supporting evidence from third parties. On expenditure management, we need to do workshops just on the contract managers to ensure that that is ingrained in the culture, looking out for expenditure management, and further implementing consequence management processes that was established in the previous year. On the revenue management side, we've implemented already confirmation step of payment and review of those documents before commencement of work, and supporting documents following through to finance before capturing on the system. The other main challenge or step is just on our retention fees in terms of our databases, with requiring updated client information and license and product information to make sure we can follow up on historical debt. During the 22-23 financial year, we did extensive work on follow-ups of historical payments that was due, and it's just to update the relevant databases with payments received going forward. On the next slide. just the analysis or the irregular expenditure balance. You'll see from 10.3 million to 3 million in 2022. Our historical irregular expenditure has been addressed in full as we received condonation process following consequence management implemented. The current year irregular expenditure mainly contributed to 3 transgressions, and the main one was due to a legal matter that required extensions and variations that was done. In terms of addressing the current year irregular expenditure as well, we've appointed a panel of experts for a legal panel of experts that can help and assist in terms of managing unprecedented or unexpected court applications. We were inundated with some of those during the financial year as well. For the remaining 3, the consequence management processes has commenced, and our intention is to clear that balance as well by financial year end. On the next slide. Just on the financial analysis, for the first time, we have generated more fee income than government funding or the government transfer received. So that's a good trajectory we are on. That would help us to fund some of our vacancies, but not all of it. An increase in our fee income is from 107 million to 181 million in the year 2021-2022. We also did see an increase in our investments or interest revenue. It's mainly due to revenue received in advance, our cash balance, receiving the money up front, and we've invested that in the Corporation of Public Deposits as mandated by the National Treasury. On the next slide. Just the analysis of our fees per function, the main categories being medicine, evaluations and registrations, inspection permits and licenses, and unregistered medicines. And we've seen an increase across the financial years on all categories except for unregistered medicines, mainly due to the nature and type of applications received for unregistered medicines. And in terms of the new medicine evaluations, seeing the throughput increasing a bit, and with the previously gazetted fees having an impact on our fee generation. Next slide, please. Just analysis of our revenue and expenditure over the past few years. We've seen the dip we had in 2021, which was a real concern for us. 21-22 showing the trajectory increasing with a accounting surplus of 28.2 million. And it was mainly due to our own revenue generation spiking in the last quarter of the financial year, and also general under expenditure on some of our line items. In terms of our accumulated surpluses, we're sitting at 53.6 million. So financial sustainability looks good as at end of 2022. The main challenge relating to our vacancies, we've got about 95 positions, unfunded vacant positions, and the annual cost thereof would be 67 million, which is the financial challenges in terms of what the CEO referred to. In our balance sheet, our liabilities mainly relate to revenue received in advance. So not a liability we expect to pay back, but to turn into revenue as the services are being completed. Next slide, please. In terms of our external funding, we had additional funding coming in from new parties, but mainly the external funding we received related to the Backlog project. We engaged Audited as well to assist us with strengthening safety monitoring systems for vaccines, and also CHAI for our healthcare professional COVID vaccine data analytics. So that was basically the main fundings received, and also from BMGF direct funding received for the Backlog project. Next slide. Thank you, CEO. Over to you.
Thank you. Thanks, Rachad. So, Chair, just to conclude, just to say that, while we've done well and have achieved in these areas, it doesn't mean that there's no room for improvement, or that there aren't any other areas that remain to be challenging. I think we've demonstrated that fairly, that there are areas indeed that we still have quite a lot of work to do. And a critical really issue is around capacitation of the organization and digitization of the organization. I think those are two important levers that will enable us to be effective and efficient as a regulator. We have seen an increase in the number of applications that are coming through. And so, we certainly are constrained, and any support we can get from the committee in terms of engaging with National Treasury to support our efforts of getting more funding, that would be greatly appreciated. We also are paying attention to legal challenges, and we have actually commenced with a process to review the Medicines Act to ensure that there are no ambiguities, to ensure that it aligns with the current context, and that it's quite relevant. So that process has started. Engaging with the public, we can never do this enough. We continuously have quite a number of webinars. I think one of the latest ones that we did together with the Minister of Health, with other colleagues in the vaccine area, was on the GBS case, the Guillain-Barré syndrome. And, we were commended in terms of how we were able to speedily report on that. The Provincial Department of Health engaged with the family. We were transparent and reported on that case. We did that in a platform wherein we can be asked questions by the media, questions by the public, and even with the second case of GBS, we reported on that quite timelessly. So really, that's how we want to operate. And the core message here is that, while we say that these vaccines are safe, effective, and are quality product, like many other health products, you do have to monitor any adverse events, and you have to do investigations on the causal link to a vaccine. And I think we've got a fantastic committee in terms of NICEC, that's chaired by Prof. Hanneli Meyer, that does these causality assessments and works with SAPRA. And just to conclude and say that, we remain, I think, to be quite a young organization. We've achieved a lot, but there's still a lot more that we must do. The area of medical devices, we've alluded to that, complementary medicines, cannabis. Really, there's still a lot of work for SAPRA to do, as our scope has increased with the establishment of SAPRA. And one other important area that we will be focusing on, as we're seeing, pandemics wherein the disease-causing agent either crosses species, etc., the area of One Health is what we will be focusing on also going forward. Chair, I'm going to pause here. Thank you.
Thank you very much, Dr. Semete and team, and Professor Alan Rees. There are quite a number of members who want to engage with you. Congratulations on your unqualified audit. And it is quite late in the day, honorable members, but let us see how this will go. The following members want to ask some discussions. It's Wilson, Van Staden, Clark, Tembakwayo, Isma, Churua, Munyai, Gela. Wilson, Van Staden, Clark, Tembakwayo, Isma, Churua, Munyai, Gela, in that order. Thank you very much.
Thank you very much, Chairperson. I hope I'm audible. And thank you to SAPRA. I think, first of all, there are some congratulations in order. First of all, on your audit results, that is always a highlight. It certainly makes us feel better as a portfolio committee that you've got the bulk of your situation under control. And then, of course, your WHO recognition in terms of your maturity levels. And I think that is a job very, very well done. It gives us faith in SAPRA. So congratulations to Dr. Semete, your team, to Helen Rees and the board. I think those are amazing achievements, and I think we must always give recognition where recognition is due. There are a couple of concerns in your report, obviously, and I think some of these you've covered. I was raising questions as you began, and obviously throughout the presentation you have addressed some of these. Obviously, the irregular expenditure of 3 million is always very, very concerning. It's not a small sum of money. And you have stated in your report towards the end, and thank you, that there is consequent management and corrective measures being put in place. We hope that obviously that will be dealt with primarily very quickly. But there is a discussion, or is an indication that one of these is a result of a legal dispute. So if you could give us some information on that, I'd be delighted. Concerns around your program 4, and that's your clinical and pharmaceutical evaluation. Now, you know, this is a pretty critical area in terms of the whole big picture of what SAPRA obviously does. I kind of got the impression from your presentation that these were as a result of possibly digital or IT failures, and that, along with your high turnover in your technical skills development, and particularly retention of highly skilled staff. I know that we produce first-class scientists in this country. Of that I have no doubt, and I'm sure that a lot of these are part of SAPRA as well. I mean, yet we do not seem to be able to retain them, and that's always an issue. Is there any plans in place to make sure that we retain the highly skilled personnel that we've got? And obviously, you are indicating that there is no budget in terms of your vacancy rate, which is concerning. And if there has been any progress on that. Very interested to hear what cases you still have before the courts. You know, a couple of times legal issues were raised. If you could just give us, highlight the backgrounds on those particular cases. And then 2 cases that are completely off the mark. In the Biz News today, and I found this most alarming, is that a senior member of Pfizer, Janine Small, made an admission that the Pfizer COVID-19 vaccine was not tested to see if it actually prevented transmissions or if it was effective against COVID-19. Now, that's quite an alarming article to read. And I would like to know where SAPRA stands on this. Our understanding is that you authorized vaccines. What kind of testing was done? If Pfizer never tested it, on whose opinion were we working, and how did we establish that Pfizer actually was effective in preventing COVID or reducing the symptoms on COVID? I found that a most alarming article to read today. And, you know, it's the kind of article that has a huge impact in a place like South Africa, where, number one, we are seeing more and more vaccine hesitancy. And we were obviously quite severely assaulted by people who were anti-vaxxers, not just you, but ourselves as well, who did not agree with this, and that it was all a plot by Big Pharma. And obviously that kind of article, you know, is kind of hair-raising. And just lastly, I want to discuss particularly coding regulations. We are seeing a big uptake in youths using codeine, whether it be in cough mixtures, whether it be in tablet form. Obviously, codeine is used in a lot of on the shelf, off the shelf. Remedies, cough mixtures, etc. They are now mixing this with strawberry drinks and what have you, and it has become, and they have several names for it, one of them being Leap. And we're seeing a big increase, particularly in very young people, of misuse of codeine. And it's because it's so easily accessible, number one, and number two, these products are principally cheap. Can you please give us some idea? And I know that pharmacists are supposed to record codeine, how it's being sold, in what format, and provide information to people who purchasing it and advice on it. And yet we know that this doesn't happen. I mean, I can walk into any pharmacy tomorrow and buy a codeine-based product without a question being raised. Can you tell us, please, what you are doing to improve the regulation on codeine sales? Because we now are sitting with an alarming situation because of its cheapness and its easy availability, and it is affecting our youth in principle. Thank you, Chair.
Thank you, Chairperson. Yeah, I had 100 questions, but I've bring it down to only 4, so don't stress about this. No, I'm also concerned about the irregular expenditure of 3 million rand. I think it's a bit alarming, and I would also like an explanation around that, please. And then you stated it was on my slide for reform report I received. I don't know what slide it is now on your side, but out of 3,300 backlog applications for medicine registrations received, you said you cleared 2,500. Can you please explain to me why this backlog happened in the first place, and also the same explanation for the medicine variations sector, please? Do you see the establishment of a backlog clearance program as a success? I understand it's working, but do you see it as a success further on in the future if backlogs arise again? And what was the reason for the decrease in the issuing of licenses for manufacturers of alcohol-based hand wraps? And what impact will this have on health facilities and so forth? And my last question is, it was on my slide 51 where you spoke about the 54 rejected products. It was 3 columns there. And the last column, if you count it together, it comes down to a total of 54 rejected projects. I just want to know what the reason for that was, please. Thank you very much, Chairperson.
Thank you, Chairperson, and good afternoon to the SAPRA team. And my congratulations also in order in terms of your clean audit. There are a couple of questions I'd like to ask. Member Wilson has addressed the Pfizer vaccine issue, and I'm also very interested to hear your feedback on that, because I've had many queries today from members of the public relating this. And also Member van Staden has covered the irregular 3 million rand. Can you please provide clarity in terms of your backlog reduction strategies in generic medicine registrations? And then how did SAPRA focus on raising funds in terms of its capacitation? I'd be interested to know how you did that. I'm also seeking clarity on staff members that were moved from the NDOH through the Labour Relations Act and transferred to SAPRA, and you know, what was the outcome of that, and why was that done? If you could also tell me how many arrests were made and how many successful prosecutions were realized in terms of illegal contraventions related to the Substance Act and the contravention of the Pharmacy Act. Can SAPRA provide a list to us? And I'm not expecting you to do this today because it's quite a long list, but if you could in future, please send us a report as to who has qualified for licenses in terms of the cultivation, manufacturing and distribution of cannabis for medical purposes. How many legal challenges are outstanding and what is being spent on legal costs to address these matters? Can we please get an update in terms of shortages of yellow fever injections and morphine powder? And can SAPRA please confirm if there are any other medicines that are within short supply that we should know? And then in instances where there are a single supply of critical medicines, has SAPRA investigated or considered the use of multiple suppliers? And regarding these shortages, has the policy on priority review pathways provided effectiveness in addressing this? Thank you, Chairperson.
Thank you, Chairperson, and thanks for the presentation done to us. And before I ask questions, I would like to say to Dr. Semete and Prof. Rees to say, yesterday afternoon, we all received an email that was from you that had inquiries on matters of secretarial nature, which had no business for it to be drawn to our attention as the committee members. And to say to you that we have the utmost confidence in our secretary, Mrs. Majalamba, who's doing a good job. So we usually don't communicate with you as an entity. And this has never happened. And I think it must not happen. It must stop here. You communicate with her about the times and everything and don't include us as members of this committee. And she deserves an apology, please. My first question is in connection with the AG on the record keeping in connection with the entity that did not implement proper record keeping to ensure complete, relevant, and accurate information to support financial statements. And I would like to ask whether this has got no implication on the employee turnover, which implies the total number of workers who leave your company or your entity. And also directly related to the statement that you are severely understaffed. And citing for an example that was presented in this presentation of an example of the resignation of the only software developer. And I would like to ask to say, which factors are leading to this, to the workers to leave your company? How open are you to do introspections pertaining to specifically the attitude towards your workers? Have you done at least a survey, a simple survey of a level of the satisfaction of workers in the work atmosphere? And say, for an example, you would have done a satisfactory survey, and one of the findings would be that the reasons why people are leaving this entity is because of the attitude that they get from the executives. What would your reason be, and how are you prepared to do your introspection so that you can be able to retain the workers that are working under you for sustainability and continuity of what is expected of you as an entity? And to continue with another question, to say, under the section of inspectorate and regulatory compliance on issuing of licenses throughout the provinces, it's very much worrying and it's disappointing. Comparatively, of all the provinces, like for an example, Gauteng submitted 86. Out of 86, only 14 licenses were issued. Limpopo 24, out of 24, only 4 issued. KwaZulu-Natal had 56 submitted, out of that only 7 issued. Eastern Cape 21, 5 issued. Western Cape 61, 15 issued. Mpumalanga 13, only 1 license issued. Northwest 16, only 5. Northern Cape 7, only 1. Free State 25, only 4. Why is this trend happening? Why is this happening? We can't understand to say why is so less licenses issued by your company. I need a reason there, a very convincing reason towards that. And there was also an issue on irregular expenditure. Not satisfactorily measures that are convincing has been presented by you here. I mean, the simplest reasons that you gave are not acceptable because irregular expenditure is committed by the top management or the executive, you haven't reported to us about issues of accountability and charging of those that are responsible for this. Please provide us with the substantial matters pertaining to this. The last one, South African Cabinet has finally given the green light to sign the African Medicine Agency Treaty and adoption of the African Union Model Law on Medical Product Regulation. Although the Complementary Medicines Regulations in 2017 under the Medicines and Related Substances Act have been declared unconstitutional by the Gauteng North High Court on the 1st of October 2020, and further invalidated and declared unlawful by the Supreme Court of Appeal on the 11th of April 2022. What is your involvement or knowledge acquisition pertaining to this matter? Are you now and the Minister of Health going to rely on the AMA and model law on medicinal products to usher in harmonized regulations and guidelines adopted by the AMA to regain full control of the domestic market? And lastly, I just would like to say, there's a statement here that is awkward to say you are the best in the world. You can be, yes, the best in the world, but the West in South Africa. That's why you will always have a lot of protest against you. Have you ever asked yourself why there are protests against our entity? Thank you, Chairperson, for this opportunity. And just to say to the Chair, if Honorable Chirwa can't be able to present the questions, I'll be able to do it due to maybe problems of being of what is it? Yeah, of electricity. Thanks, Chair.
Honorable Ismail.
Chairperson, Honorable Ismail did send a message on the group to say she's got no connection. She would not ask questions. Thank you.
So back to you. If first, Honorable Chirwa, if she is able to, otherwise, Dr. Temkoyo.
Okay, thank you, Chair. Let me read Honorable Chirwa's questions. Who are the sponsors and founders of SAPRA? And what is the relation or working relationship with each sponsor? What are the programs SAPRA is working on with persons associated with or involved with their sponsors? And what are other links not overtly stipulated? E.g., Bill Gates funded SAPRA previous years. Bill Gates associated vaccine approved. Why didn't SAPRA pull out Pfizer following the release of the possible adverse effects that Pfizer had hidden from the public? Was SAPRA aware of these leaked documents prior to them being leaked? And what was the response thereof, noting the possible medical implication this was potentially going to be? Is it true that Pfizer has applied for dilution of current Comirnaty vaccine to be used in children? What is the process of scientifically verifying this data? Is it dependent on their submission, or is SAPRA going to conduct their own investigation on this? How many cases have been reported to SAPRA on adverse effects and alleged deaths due to vaccines? How many are being investigated? How many investigations have been concluded? Please appraise the details. In connection with wasteful expenditure, irregular expenditure, on the 2nd October 2017, Medicure Sustainable Healthcare Solutions Pty Ltd was issued a license in terms of section 22C in brackets 1 in brackets B of the Act read with the regulations by the South African Health Products Regulatory Authority. In terms of Medicue's license, it is permitted to manufacture certain medical devices, including reprocessed single-use devices, and it is permitted to import certain reprocessed SUDs. The company provided the independent validations in 2017 to SAPRA and also received its first contract with Netcare. SAPRA direct emails to Netcare ended this contract in 2018. In 2019, validation results were sent to SAPRA for a second time after they requested via a virtual meeting. The validation process, which is FDA approved and which Medicue submits to, was also submitted to SAPRA in 2020 with no feedback received from SAPRA to date. Please appraise the committee on why this case was handled in this manner and why SAPRA hasn't responded yet since 2020. On behalf of Honorable Chirwa, her questions ends here. Thank you, Chair.
Honorable Munyoy, followed by Honorable Gela.
Thank you very much, Honorable Chairperson, and thank you for the presentation, Professor Rees and the CEO Tumi. Without Chairperson, Honorable Chairperson, without exaggeration, I'm so thrilled that SAPRA achieved maturity level 3. And congratulations on your unqualified audit achievement. Your accomplishment is way above and beyond our expectation and satisfactions. I'm incredibly proud of SAPRA and the achievement. We have no doubt that they work very hard. We understand the history, where they come from. We understand, we know the backlog SAPRA inherited. And before I go to other details, Honorable Chair, because as members of Parliament, we are very astute on the matters of international relations. South Africa is interconnectedness, interdependent with any other countries across the globe. The drugs SAPRA approve are not only coming from South Africa alone. Majority of them are coming from the international market. So therefore, SAPRA have to collaborate. We appreciate that they collaborate with individual business people, multinational companies, and so on, to be able to approve the drugs to protect our populations, and at the very same time, generate revenue to sustain this regulatory authority. And we also appreciate that the decision is scientific evidence-based decision. It's not a political influence decision. So therefore, the mistake SAPRA would have made, we understand where you have started and you have presented that particular progress. So we must encourage you so that you continue to work very hard towards achieving a clean audit. A member of Parliament, you can't come here all the time like you are coming to slaughterhouse. We must encourage you so that you achieve accountability or oversight we do over this organization. It's not macromanagement of the organization, and it's not that we should be hard on them. It's about encouraging the organization. We must work together so that they succeed. In all the out of all the entities that came before us, SAPRA is the only organization that went to Treasury to condone. Some of the organization entities here, they never went to Treasury, which is a fundamental mistake. So SAPRA has done everything not to hide the weaknesses they've experienced in the line of their operation. I'm so proud of this organization, Honorable Chair. I must say, for me today, I have no question for you because the report is so solid, it's exciting, and we must congratulate you. Thank you very much indeed.
Thank you very much, Chairperson. Let me also welcome the report from SAPRA and also their achievement for getting ML3 for vaccines and also regulatory oversight, including ML4. We are so proud of you. Of course, I was having a lot of questions that I wanted to raise, but during the presentation, some of the questions were answered, especially on the financial statement and also on the concern that the AG has raised, and also on the irregular expenditure. I think the CFO have touched what happened to have irregular expenditure and also the consequence management, and also that at least you were so transparent. I think you were good in your presentation and telling us everything that is happening in your department, especially as in your conclusion, you highlighted that this is still a new baby, a young baby institution. There will be some mistakes, but the way you are implementing your program so far, and in some of the question, I think Honorable Mnyai have said it mouthfully. Chair, I don't want to waste time because really other colleagues have raised questions, and some of them, the presenter and also the CFO have touched, but further than less to say that if we can just speed up the issue of staffing, because on your program 4, it's where we are lacking and it's your core function. And I believe and trust that you are going to correct that so that at least come and next financial year we'll get better results in terms of what the Auditor General have raised as a matters in your report. Thank you very much, Chair.
Thank you very much, honorable members, for the
Lastly, Chair, I think as members, through you, Chair, my apology, but I think it's important for us to support SAPRA as portfolio committee so that at least we give them support where it's necessary and also work with them. Thank you very much, Chair.
Yes. Thank you very much. Also, I had already congratulated SAPRA on achieving an unqualified audit, and also the other 2 awards, which has been raised now a number of times, and then also for Professor Rees with the order that she received from the French government. You are it's well deserved, and congratulations to you too in your personal capacity. Then I want to just speak about your surplus and your increased revenue generation capabilities that you've been able to develop. And we will remember that it was a challenge before. We do note the number of applications had increased tremendously. So I would think that that allows you to have this increased revenue generation. But if at the same time, you could maybe just tell us what you're planning to do with any surplus that you might have, and how you would be able to apply some of these to fill some of the vacant posts which you currently experience. We've heard many of the members refer to the challenges with staffing or filling of posts, etc. But be that as it may, I'm going to quote what Honorable Monia said, and he said we need to encourage the organization. And really, we should encourage you. You've done very well from understanding where this has come from. How young this organization is, a responsibility that was there. It's a major responsibility to have to decide what is good for the people and what is bad for the people, and what is good for individuals and bad for individual people. And it is surely not an easy task. It is, and you're correct, to base it purely on the scientific evidence and the best scientific evidence. And I know you also hold the gold standard of random clinical trials as the best measurement by which you decide. And so from that perspective, I want to commend you for holding steadfast to the principles of scientific evidence in your decisions which you have to make. We also understand that there are many people who have interest in devices or medicine or pharmaceuticals, drugs, etc. in terms of the financial outlook that they have, that they need to make money from these kind of products. And imagine that there was no control over these products in any market for that matter. I note the medicine which was sold in one of the townships in Cape Town. I was quite disappointed to actually see that there are individuals who sell scheduled medicine at the hawker stations or on the street corners. And if it wasn't for an organization like yourself, we would surely have been in terrible problems in South Africa. And when one watches programs, for example, in the USA, and you look at the opioid challenge which some of these countries are having, especially Canada and the USA, then it encourages one even more that we have people like yourselves who are always there, available, looking out for these kind of challenges, have the courage to go and investigate, and have the courage to bring those to the attention of the SAPS and other law enforcement agencies. So you need to continue doing that. You need to continue to improve towards a clean audit, which you're hoping to achieve. We hope that you will be able to achieve that by next year. And I also note your request for engagement, the Portfolio Committee to assist in the engagements with the National Treasury, for you to receive more funding, and also your discussions around the review of the Medicines Act. So we are in full support of what you are doing. We are really encouraging you, and you have many questions to answer raised by the honorable members. I'm going to allow you that space. It is now 18:31, and we're hoping to be completed by not later than 1900 hours. Back to you, Professor Rees and Dr. Semeti.
Thank you. I'm going to invite quite a lot of the questions were pertaining to the operational aspects. So I'm going to ask Dr. Semeti first to come in, and she can guide the questions also to her colleagues, and then I'll come in after her. Thank you.
Thank you. And thanks, colleagues, for these questions. We've clustered them around finance. There were questions around our core business, questions around HR, legal, medicine supply, and I guess the overall SAPRA operations. So we'll start with finance, and I'll have Rahad handle those questions.
Thank you, CEO. Just to provide a little bit more detail on some of the irregular transgressions. So specifically on the legal disputes that we had in the span of 1 to 2 weeks, 4 urgent court order applications that had to be addressed. And basically that's, if I can recall correctly, related to compounding of medicines from various court applicants. So SAPRA had to respond in quite a fastidious manner and in a specific time frame. Also, in terms of the legal costs, you would see in the financial statements, and it's also reflecting there the legal proceedings against SAPRA in the 21-22 financial year, where the expenditure increased from 2 million to 7.5 million. In terms of our condonation process or our consequence management process, you will see the reduction in the overall balance, and also to remember that National Treasury will not condone irregular expenditure if consequence management has not been implemented. So we have established quite a robust loss control function. We do determination reports to identify liable officials, and then to issue or implement the consequence management, of which the proof will then be submitted to National Treasury before they will consider condonation of that process. So we've done a lot of work on irregular expenditure. We've updated SOPs, we've established or filled vacancies in the SCM team. We have also training and workshops initially earlier in the financial year. And this all will build a culture of improved governance and controls over our SCM process. And historically, we had over, I think, 30 transgressions that we were able to bring down to 3. And it is management's intention to submit the condonation requests within the next month to National Treasury to get those processes condoned. In terms of budget on vacancies, you will also see in the annual report a growth in our cost of employment year on year from 147 million to 182 million. And for this year, we've budgeted 207 million. So all the additional revenue that we generate mainly focuses on filling of those vacancies. And I think we've got about 40 vacancies planned to fill throughout this financial year. The cost of which is quite expensive. And to the question on how our surpluses will be utilized, we did receive approval of our surplus from National Treasury, but they did caution us not to use it for filling of vacancies. And the reason for that is the surplus is a short-term turnaround, a short-term profit, basically. And we should be shying away from utilizing surpluses to fund permanent vacancies that has a longer duration. So all effort, it is on top of mind for management and the board, allocating funds what we can to fund our vacancies going over the MTF period, and hence also just requesting additional assistance as the filling of the 95 vacant posts is quite a big amount. It's a long-term commitment. It's over 67 million rand. On the application of the surplus on other projects, so what we'll be focusing on is some of our capital projects, digitization of systems to get us away from manual processes that are resulting in potential audit adjustments and so forth. Potential short-term contracts, maybe to just fill a gap for a specific duration. And that is currently the envisioned strategy on utilizing our surplus. There was a question on record keeping from the AG. How did that affect staff turnover, or maybe in terms of the staff issue? And just to indicate that specific record keeping related to the audit adjustments that we made on our commitment notes and our classification of services in kind, and some other minor adjustments as well. So not specifically raised in that context. Thank you, CEO. I think that was the questions on finance.
Thank you very much, Rehat. I don't know if Prof. Rees maybe wants to come in on the, before I tackle with Portia some of the questions around our core business. If you want to comment, Prof. Rees, on the vaccines maybe, or the backlog, and then I'll come in.
Thank you, certainly. And I'll put on a hat because I work closely with WHO on vaccines generally and chair the African Committee for the WHO. So on the Pfizer vaccine, the issue was, and the concern was in the article, thank you for bringing that to our attention, was that there was not data on whether or not the vaccine prevented transmission. Now, in fact, it was very well known that there wasn't data for any of the vaccines, frankly, on whether they prevented transmission. When the clinical trials were done for all of the vaccines, all the COVID vaccines at the outset, the priority was, does this vaccine work in terms of preventing severe disease and death, and is it safe? And that's what we got more rapidly out of the trials. The transmission work is being done now and will be done in the future, because clearly first prize when you have a vaccine for any infectious disease, you want to prevent severe disease and you want to prevent transmission. That means you want to stop people transmitting from one person to another. So for none of the vaccines did we have data on transmission. So for all the vaccines, what we looked at, safety, quality, and efficacy, and particularly efficacy at preventing severe disease, hospitalization, and death. What we can say for the vaccines that are now registered in South Africa is that all of them have demonstrated an ability to prevent severe disease, hospitalization, and death. And all of them are being monitored for safety, and all of them are regarded as safe. The second question was the serious adverse event for Pfizer. Now, for many vaccines, when you start to roll them out, instead of having clinical trials on tens or 20,000, 30,000 people, you're suddenly rolling them out into populations of millions. And that's where you'll see if there are going to be rare, what we call adverse events, side effects. If they are very, very rare, you will only see them when you introduce the vaccines into a much, much larger population. So for Pfizer, the very rare side effect that was seen was what's called myocarditis, which is inflammation of the heart muscle. On the other side of it, COVID also causes myocarditis and at a much higher rate. So the benefit of the vaccine far, far, far exceeds, even for myocarditis, the risk of COVID. We've also had, and this was what was just reported, we've had two side effects, serious adverse events with the Johnson & Johnson vaccine. One was what was called TTS, which is a clotting disorder. And the other one was the one that has just been referred to, which is the Guillain-Barré syndrome, which is a disorder of the nervous system, broadly speaking. And in both cases, these are extremely, extremely, extremely rare side effects of the vaccines. And what you do when you get anything like this, you then look again and say, does the benefit exceed the risk? And in all cases, the benefit of these vaccines, even with these extraordinarily rare events, the benefit of the vaccine exceeds the risk, because in fact, for many of these things you see, such as a clotting problem, you get many, many more clotting problems if you get COVID. So as I say, what we do know is that these vaccines are protective against severe disease, hospitalization, and death. And I think that's extremely important. I'm not, so I'll perhaps stop there and be very happy to take further questions. In terms of the backlog, where did the 16,000 come from? So I'll start on that, and then Tumi can also come into this later on with colleagues with the CRO as well. So when the Medicines Control Council was transformed into SAPRA under different legislation, there were several aims, but one of them was to make SAPRA a much more autonomous organization in terms of being able to do a lot of the work in-house instead of outsourcing it to other academic experts. The old way of reviewing registration dossiers from the Medicines Control Council was kind of designed for building a backlog. First of all, it was completely paper-based. So any one of these applications, you could have 16, 20 huge big boxes of paper that had to be gone through by different experts. Secondly, there was a referral. A lot of the review was done by external academic experts, but there weren't sort of standard operating procedures or agreements with those people about timelines. So somebody could be very good and very fast and very efficient, and somebody else could sit with those evaluations and not produce anything for a really long period of time, because they were not, their contract didn't say, this is the timeline in which you're going to deliver. Now, the combination of these and the approach to evaluation, which was an approach that was appropriate for a Medicines Control Council 20 years prior, but wasn't appropriate and wasn't fit for purpose for new generations of drugs and much more data to review. That approach, all of those three things together, meant that we were never, from the MCC point of view, it was never going to be able to keep up. And so that, you know, you're never going to be able to keep up. And that's where the 16,000 came from. But SAPRA recognized that. It was one of the key priorities. If you have a backlog like this, if you're inefficient as the regulator, then what you do is you stop products getting out into the public domain for community benefit. You stop the benefits to public health. That's problem number one. And number two, if you have, say, local manufacturers who want to register their product, then you're also preventing the development of local industry. So it was seen as critical for SAPRA in its first year to get rid of this backlog. But in order to do it, we couldn't have done it using the business as usual model from the MCC. So we had to go through an entire process of evaluating the way that we were reviewing dossiers, streamlining it, looking at what is state of the art nowadays in terms of regulatory methods to review. And all of that was done. And I'll hand over to the CEO, because not only did we do it for the backlog, but what we're now doing is we're saying that is now moving towards state of the art. We do not want another backlog to build up. And so all of these approaches that have been adopted are now being introduced into all of the new applications and their review as well. I hope that explains that. I'm happy to come back in on any other matter. Thank you.
Thank you very much, Prof. Rees, on that point. If I could just pick up then on the Pfizer, as there were more questions around this, with reports around the adverse events following immunization, and that was the report from the US. We have issued, and this was a few months back, we even issued a statement as SAPRA in response to that, but also indicated that Pfizer does report to SAPRA what we call our periodic safety reports. So they have they're accountable to ensuring that reporting on any adverse events following immunization is done to the regulator. So we noted that report from the US, but we stated then the context, the local context in South Africa. In terms of the RTU formulation for pediatric populations, we have indeed received the submission for this. As a regulator, we don't conduct the tests ourselves. We then review data that is made available to us, and this applies across the board. We're not a research institution. And so we would then review the data that Pfizer would have then made available to us. I want to also maybe just comment on while we're talking on adverse events following immunization, there was a question around the numbers. Again, this is available on our website. We have a microsite. We update it quite regularly. And so we are transparent around the number of reports that we receive. Out of the 37 million vaccines that have been administered in the country, we have received 6,900 adverse events following immunization. And we provide details on these in terms of some of these are just a sore arm, fever, etc. And the majority of them resolve within a few days. And this represents a reporting level of 0.02 for both the Janssen and the Pfizer vaccine, and very comparable to what we're seeing across the world. So these are the ones that resolve within a few days. We have had cases of death being reported. Again, this is available on our website. We indicate the number that we have evaluated, and to date, we have evaluated 192 of these 217 deaths, and we have found those to be coincidental. We go into a lot of detail on this also on our website. So I do believe that that information is available. There are currently 25 that are being investigated. We have reported on the 2 deaths related to GBS that were causally linked to the vaccine. So we can say with confidence that we have only reported on 2 deaths related to the vaccine. The rest are either coincidental or the individuals had other comorbidities. And we are then evaluating the rest. I'm also going to then reflect on the African Medicines Agency, and indeed we're quite thrilled with the developments in this area. And for us as SAPRA, we participate on the continent on all of these numerous platforms. It really gives impetus to what we do, this progress around AMA. And indeed, you made reference to the model law. So while AMA would be an African platform that supports harmonization, and in the short term will focus on advanced therapies. Every member state still has autonomy. So we would still have our Medicines Act that guides how we do what we do. We would still have our own regulations, but there would be instances wherein we say, all of us as regulators, once a decision has been made through AMA, how will that then be implemented at a country level? But every country still has its own autonomy. There was then a question around the complementary medicine and the legal case around that. Indeed, we have accepted that, and we again issued a statement to this effect. We are reviewing the regulations, and really at the core of this, it was what was being challenged was the definition of a complementary medicine. The outcome was that our definition of a complementary medicine is too broad. It may even include products that are not necessarily medicines as per the definition in the Medicines Act. There was a clear acknowledgement in this court decision that complementary medicines have to be regulated. However, SAPRA needs to ensure that the definition is indeed within the scope of what a medicine is. We've been given 12 months to amend the regulations, and that's a process that is currently ongoing. I'm going to then reflect on two other matters and hand over to Portia. I'll reflect on cannabis in terms of why the low numbers. Again, this is an area that we have seen a surge in applications. We are undercapacitated. We will not be able to increase the number of licenses that we issue. And also just to indicate that prior to issuing a license, we have to go and inspect a facility. So that means that, you know, and at a time we send 2 inspectors, and as I say, we're undercapacitated. They go and they assess the facility. They look at the submitted information and then make a recommendation. At times, even a recommendation that we make requires a bit of back and forth. So the numbers that we've seen as it's after, you know, we've really put a lot of effort into ensuring that we support this area, but we genuinely are undercapacitated to deal with the number of applications that have come through. The last one that I'd like to reflect on before I hand over to Portia is around Medi-Q. And I really just want to correct the statement. It is false that we have not engaged with Medi-Q since 2021. The most recent communication to them was now at the beginning of October. We have had numerous meetings with them wherein we have asked for data, wherein they confirm with us that the quality of the products that they repurpose still meets the requirements. They have not been able to give us that data. And in the absence of that data, we cannot authorize that they proceed because it puts the lives of the public at risk. They have products such as catheters that they have started to repurpose. And you need to make sure that those are compliant because these are products that are inserted in a person's body. So we have engaged with them. And as I say, the most recent communication, it's a letter actually that we issued to them, was as recent as beginning of October. I'm then going to hand over to Portia to talk to Codeine, as well as to talk to the priority review process.
Thank you, CEO. Good evening, honorable members. I'll start with the response to the Codeine matter. Yes, indeed, this was also an issue for us as the regulator, where in September 2019, we started to conduct a review of the, whether to reschedule or upschedule the Codeine in light of the concerns on the misuse and abuse of this codeine-containing medicines. What we did was that we requested for sales data, that is for domestic import and export of all codeine-containing preparations for the time period of January 2018 to January 2019 from the industry. We did that in December 2019. And the takeaway points from this analysis was that there wasn't a large increase in manufacturer reported sales volumes between this period. However, there was a high proportion of the sales volumes which was attributable to small number of manufacturers, and that specific codeine-containing medicines. These were dominated by the Atcodols, Bronclear with codeines, the Mibulin, and the manufacturer sales were predominantly to wholesalers and final purchasers, that is the community pharmacies and hospitals, with a small proportion to authorized prescribers and the state. So there are concerning signals that individual final purchasers, which has the community pharmacists, could be responsible for disproportionate volumes of purchase. What we did, we had Bronclear with Gauteng, which was on the top list, and Gauteng province had over 90% consumption rate. And we started our investigations in the Gauteng province, and we wanted to ascertain if there were leaks in the supply chain to illicit market, and also to collate information to guide on appropriate action that would be needed. And our investigations were throughout the supply chain sector, including manufacturers, wholesalers, community pharmacists, clinics, including prescribing doctors. And what we also did, we had several meetings with the manufacturer of Bronclear, with Gauteng, and where we reviewed consumption data and also requested control of production quantities. And we also filtered the top 20 consumers and flagged those, and we allocated them for investigations. What we did was that we had unannounced inspections, which took place since December 2021. And we also had several meetings with the producers of the active pharmaceutical manufacturer. And what we also found out is that with their follow-up meeting that happened in June 2022, there was a significant decline in the 2022 production demand compared to the past 2 years that we have noted. This was also attributed to SAPRA interventions. And we also had meetings with wholesalers. We had webinars with the pharmacy communities, the SAPC, Pharmacy Council, PSSA, civil societies, the recovering users, pharmacy industry reps, and so forth, including the Gauteng Care Initiative groups, to talk to this issue of abuse. And from those investigations that we did, those that were found guilty were reported to the Pharmacy Council and to the SAPS for further investigation and action. So this is what we did with regards to with Gauteng. So which one is the next one, CEO?
A priority review, and if you can keep the responses brief, Portia, as we're running out of time.
Okay, thank you. As a regulator, we put together a mechanism that will help respond to the public health needs and also respond to the burden of the disease in the country, looking at those products that will be containing or that will be used for HIV, that will be used for cancer, that will be used for TB, and also the vaccines. And this process has really made a great improvement with regards to the registrations of these products, in that it's taking much shorter with the review of once an application has been granted the priority review status. Yes, CEO, I'll stop there.
Thank you very much, Portia. We'll now then take, and I hope we've covered all the questions around that. We'll take the HR questions, and I'll make some few comments, and my colleague, Mr. Gordon Tagatu, will come in. I just want to talk to, there was a question around funding, how we receive, how the funding that we spoke about for capacitation. The bulk of it has been through the National Department of Health and Global Fund. A number of you may be aware that the Global Fund funds a lot of programs in the country through the National Department of Health. And so we've been able to secure funds over instrument with the Department of Health. There was a question around, in the terms of staff satisfaction, how staff reacts to attitudes of the executives. I'm not clear on that one. So yeah, maybe Gordon can speak to that, because it's quite a vague question for me. But Gordon, do you want to comment on retention strategies? Do you want to comment on the Section 197 process and our plans around staff satisfaction? Thank you.
Thank you very much, CEO. and good evening to Honorable Chair and Honorable members and the board of SAPRA, including you, CEO. I'll start with the retention strategy. First of all, employees need to be engaged with. So the CEO of SAPRA has regular engagements with employees. They need to have an idea where the organization is going. We know where it comes from and what we need to achieve and where we are right now. In addition to that, as part of the retention strategy, we make sure that the employee value proposition is understood, and therefore activities like allowing employees to have the hybrid remote working arrangement is also part of the retention strategy, because these days we're moving with the times. We don't want people to behave the way they did before the COVID lockdowns. Therefore, by allowing employees to work virtually on certain days of the week, that is part of the retention strategy. And also promoting employees within the organization. When there's opportunities, you give the first preference to the qualified, meeting the minimum requirement of the position to internal before you even go outside. That becomes one part of the strategy involved in retention. And again, I'll go back to the engagement with the CEO when the employees ask questions and they come with recommendations and suggestions. Those are listened to and therefore actioned, and they can see the action. And when it comes to the transferred employees from the National Department of Health to SAPRA, we had 196 employees that were transferred under Labor Relations Act, Section 197. Those employees are made up of employees with like 40 years service in the public service, all the way up to the most youngest transferred employee would be like 5 years. So those employees, out of the 196, right now we have around 180 because others went on retirement. And what happens is they have to understand the new culture, because you're taking a culture of individuals coming from the public service, the one that is built for SAPRA, as well as from employees who are recruited from the market in South Africa. So at the end of the day, the 196 employees, we did have to transfer them away from the PESAL public service payroll system into the SAGE. It was not 100% smooth, but it happened, and all the issues and concerns on certain benefits that are within the government. And now because according to Section 97 of the Labor Relations Act, employees cannot be worse off. But at this moment, all those steps that need to be followed have been followed. And when it comes to employee satisfaction, I'll link it to the survey. We had employee satisfaction survey 2020-2021, and we had recommendations. And out of that, during the survey, 60% of the employees participated, and the recommendations that came from the survey got implemented. And for instance, you will note that as part of satisfaction, when employees have been working simple thing as a desktop computer for 20 years, and then the next thing you give them laptops, you train them how to use these laptops, it changes their life, because now they understand the difference of telecommuting, which is virtual and remote working, because now they're no longer working with the desktop. And also, which was very exciting for me to see, we had employees who've been working in the organization for more than 20 years, who are in admin. They had to fly over from Cape Town to Pretoria to learn about computers, because some of them were working with hard copy files only. And now, because we've introduced these computers, and now they're working in this new way of doing things. In addition to that, I'll also highlight the fact that in the organization, everyone from any level, we can tell you the pillars of the organization, that is safety, efficacy, and quality, including performance. So overall, if you look at it all, at the end of the day, listening to the employees, we know there are challenges that need to be addressed, and we listen to what they have to say, and where we cannot, we explain why not. I will submit at that point. I'll take anything that I might have missed. Thank you.
Thank you very much, Gordon. I'll take the questions on legal matters. I may not have all the numbers tonight, but in terms of the cases that are before the courts, there is the ivermectin case. Again, we have issued our statement in terms of our position, which is very much aligned with the court ruling and decision that we will continuously monitor the data. And as we get the data, we will then communicate with the public. And there was a communication to this effect about a few months ago, but that matter is still with the courts. We also have two matters with the court on the vaccines, largely the Pfizer vaccine. One matter, we've received feedback recently that it will be withdrawn by the applicant, and there's one matter that is continuing. But I'm happy to provide a detailed report on this to make sure that you have an extensive list. In terms of the number of arrests, again, I can't say offhand. We work here with the South African Police Services. And when then the matters are finalized, they then do make certain arrests. You may have seen some in the public, particularly regarding to COVID-related products, but I'm also happy to come back to you on those numbers. In terms of protests to the regulator and how that links to us saying that we are a globally recognized regulator, compliant with good review practices. You know, the public has a constitutional right to protest. So I don't think we can link to the protests to our functioning and how we fare at a global stage, because they look at our regulatory processes. If the public is unhappy with the decisions that the regulator makes, they definitely have their constitutional right to protest. But also even within our Medicines Act, we do have a section that says if an individual is aggrieved or not in support of a decision that is made by the regulator, they can appeal. So, you know, we don't mind, such practices, but we need to ensure, as I said earlier, that what we do is evidence-based. And this is what the global standard then demonstrates. I'll move then to the medicine shortages. Indeed, we have been, we were made aware a few weeks ago around the yellow fever vaccine. And, you know, we did our part in terms of ensuring that we fast-track the lot release. So what happens is the yellow fever vaccine is imported into the country. When it arrives, we have to scrutinize it and take it through a rigorous quality assessment. And because of the shortage that we had at the time, we reviewed it, quite quickly and indicated with the applicant that we will then continuously monitor. We haven't, had any new applications for a yellow fever vaccine that has been submitted to SAPRA. In terms of morphine, indeed, we also are aware of that matter, and that I think there's a single supplier in the country. I just want to clarify that as a regulator, we cannot get involved in kind of market dynamics, right? We only deal with what is then being provided to us. And then when we are asked around from a regulatory perspective, our role is to ensure that wherein there's a shortage, we fast track the regulatory review, but we cannot get involved in the market dynamics. And then lastly, on the matters of how SAPRA was established and sponsors, just to say SAPRA is a Schedule 3A public entity. And hence we're sitting here today to report to Parliament, right? So that's how it was established. It was established as per the Medicines Act that we've made reference to. In terms of our funding, again, we're very transparent about this. You will see it in our annual report, the most recent one for 2021 that has been published and we've shared with yourselves today. And you will see a lot of detail in the annual report in terms of what we receive from the National Treasury, what we raise through the fees that we charge. These are fees that are gazetted. So again, there's transparency around that. And also we declare any funding that we receive, whether it's in-kind funding, we have declared that, and whether it is funding directly coming to SAPRA, we have declared that. And those are the practices that enable us then to get this unqualified audit opinion, because we're transparent and we've got mechanisms to report and to manage that. So in terms of where we've received our funding, as I've said, National Treasury fees, But also for specific projects, we have, as I've indicated earlier, that we have funding from the Global Fund through the Department of Health. Even in the past, they funded the Backlog project through the department. We also had CHI, the Clinton Health Access Initiative, that funded also the Backlog project. There's a number of other projects that they are funding us, and also we have the Gates Foundation. One of the things that we made sure that we put in place to ensure that there is no conflict of interest or any even perceived conflict of interest, we've got a policy that says any funding we receive has to comply with that policy. And so this is a review that we apply with any funding that comes through. We review the contracts in detail and ensure that we are compliant with that policy. This again, we report to our board through the Risk, Audit and Governance Committee. Thank you, Chair. I think I've covered all the questions.
Thank you very much, Dr. Semete and your team. I think you certainly have. I'm going to give just 30 seconds to your chair of the board to say a few words, and then we're going to close this meeting. Thank you very much for those replies.
Thank you, Honourable Jacobs, and thank you to the CEO for those answers. But thank you for the questions. I hope that we have answered, but we'd be very happy to provide additional information as required. I think the one thing with the kind of probing questions that we're getting, it's very clear, A, that there's a huge interest from the Portfolio Committee in this field. But secondly, I think it reflects the importance of medicines regulation in its entirety. And I'm going to reinforce this. A regulatory authority in medicines regulation has to be independent and only look at the evidence. As the CEO said, we mustn't get involved with the commercial market. We don't get involved with the pricing. That belongs to the Department of Health. We don't do the research ourselves. Our role is to be the regulator and say, have you done all that you should do as an applicant? And having done that, is what we're seeing still safe? And so there are two sides to this, and it is for all of the products that we govern. We have got further to go, but I would like to say that the board is very committed. This is the first year of a new board, some old members, some new members. A lot of focus has been given to governance and a lot of commitment, as you can see from the attendance at this meeting from the board. But I think the board has huge confidence, as you've seen in the executive team. We do have problems, we know that, and we are going to continue to grapple with them. But we really have come a very long way, and we'd be very happy to continue to engage with the Portfolio Committee as you require. Thank you so much.
Thank you very much, and I agree with you wholeheartedly. And you need to stay steadfast as you had. I'm sure you will continue to do that, and we wish you well. Honourable members, that brings us to the end. Just a reminder for tomorrow, 2 o'clock, 1400 hours, National Department of Health, APP. So be prepared for that and have a wonderful evening. This meeting is adjourned. Thank you.
Thank you.
Thank you.
Thank you, Chair.
Thank you, good evening.
Thank you, Chair.
Thank you to everyone.